Okay, we'll continue on this section on neurological diseases. This part of the discussion is not going to cover some of the basic neurological discussions, which are going to be covered further down the road in trauma anesthesia. So I'm going to go into a lot more detail about what you do, how do you manage these cases in trauma anesthesia. So when we come back to it, yes? This one is being recorded right now. Okay. So there's certain things that will not be covered on this lecture that you'll see in the book. But I will go over it in neurotrauma again. We'll go over spinal cord injury. We'll go over brain injury, traumatic brain injury. We'll go into how to manage elevated intracranial pressure in more detail in the trauma section, which is more appropriate. So this is more of a discussion about neurological problems that you may encounter. It's not going to cover everything, but it's going to cover a good majority of what you may actually see in your career. What we're going to talk about is a little bit about increasing intracranial pressure problems, intracranial tumors, very little bit about disorders of impaired brain function, which I'm going to talk yet about that in trauma. We'll talk about semi-comatose states, coma, in that section. We'll spend a lot more time on cerebral vascular disease, vascular malformations, congenital anomalies, degenerative brain diseases, and then we're going to come back with seizures at another time. We don't have enough time to cover that all today. Now, one of the things that you encounter in discussion about neuro is all the time is about elevations in intracranial pressure. There's only a fixed amount of volume that you have inside your skull. Okay, and that's comprised of three elements: brain, CSF, and blood vessels, of which the blood vessels are the least amount. Okay? The greatest amount is, of course, brain tissue. If you increase the volume of any one of those, okay, there's no place for the brain, for the skull to expand. Okay? As a consequence, pressure will begin to increase. And this increase in pressure, if it continues, will begin to exert pressure on surrounding tissue, okay, which includes, of course, the brain. So one of the things that you've got to think about is what causes this increase in ICP. And these are usually space-occupying lesions. Okay? So anything that increases the actual tissue volume of the brain, such as tumors. And these tumors can be benign or malignant, and they can kill you just as fast. It doesn't matter if it is malignant or benign. If it increases your intracranial pressure, it usually will induce seizures, headaches, and focal neurological deficits, and actually may induce strokes as well. So when you hear people tell you, well, it's a benign brain tumor, it still needs to be taken care of. The difference between benign and a malignant tumor is that benign tumors tend to stay encapsulated. They're easy to delineate the outer layer from the surrounding tissue, which means that they're resectable. That's what makes them benign. It doesn't make the word when people hear that the person has a benign tumor, they imagine that it's a benign disease, but that's not the case when you're talking about the brain. If you have a meningioma, which we'll talk about later, that can kill you pretty quickly, and or can come on very slowly depending on how fast it's growing. The other thing that you will see is, besides an actual increase in tissue mass, is that the cells themselves can suffer from different disease processes that will induce them to swell up, which we call edema. Cerebral edema is poorly tolerated by a human being because, of course, our brain is our main system of actually controlling everything. And brain edema can become a very rapid problem in the sense that it can cause the tissue right next to it to become ischemic and then induce more edema. And if you continue having more and more edema, eventually you have an elevation in intracranial pressure, which can lead to herniation. So we'll talk about brain edema a lot in trauma because brain edema can be induced just by deceleration injuries. Just by shaking somebody, you can cause brain edema. Okay? So it doesn't take that much force. The other thing that will also increase the space, of course, is anything that increases vascular volume. Vascular volume accounts for only about 4% of the total volume inside the brain, so it's very small. So usually it's not an issue. In some congenital malformations, the veins will actually become too large, or the arteries will become aneurysmal, and they will start causing volume problems and cause compression and eventually pressure injuries to surrounding tissues. Malignant hypertension, of course, is something where you get an elevation in blood pressure that's so high that you increase blood flow. Usually people will complain of severe headaches. If it continues, the malignant hypertension will burst the capillaries and will cause subarachnoid hemorrhaging, which of course has a very poor prognosis. These are called vascular accidents. The vascular accidents will be discussed in a lot of detail, in much more detail in trauma, because things that we'll deal with in trauma are things like subdurals or epidural hematomas. That's not going to be discussed today, but we will get back to that. The other thing you'll see that also increases the ICP, which is the other area that increases volume, is CSF. CSF is very important as a brain has no lymphatics in it. Okay, so basically what the CSF is really doing is that it acts as a conduit to remove waste products in the brain. It helps remove it. Okay, so it acts almost like a lymphatic system. CSF also acts as a lubricant and also as a suspension device to hold the brain inside the skull. The brain basically floats inside your skull. And your brain should not be touching the side of the walls, the meninges, normally. Instead, it floats with CSF all the way around it. And if you drop CSF volume too fast, you can actually cause severe problems such as posterior puncture headaches. You can also cause herniations, and you cause death. So don't take it lightly when people tell you that you have a posterior puncture headache problem. You can have significant complications with that. Where you see in this area, the reverse happens if CSF is being overproduced, if it's not being reabsorbed, or it's obstructed in its passage from where it's being produced. It can lead to an increase in volume inside the brain, and will lead to what's either called hydrocephalus or the associated problems. Now, the other things that will also cause an increase in ICP are things like benign intracranial hypertension and normal pressure hydrocephalus, which we'll go into details here. When you look at CSF production, the first place where most of the CSF is produced is in the choroid plexus that's located within the lateral ventricles. And the lateral ventricles are located in each side of the hemisphere. If you look at it from the standpoint of a child, the lateral ventricles are actually almost slit-like. They're really, really small. As you get older, the ventricles begin to enlarge. The reason that's happening is your gray matter begins to degrade and become less in number as you grow older, which is a problem in the sense that as you become an adult, if you suffer any kind of brain injury, you're less likely to come back from it than compared to a child. A child has a lot more gray matter and is able to reconnect a lot of parts of the neural network to try to establish normalcy back up. So you can see that significantly when you look at MRIs in children in comparison to adults. The ventricles are really, really very small in comparison. But anyways, the actual CSF production in the actual ventricles is through the choroid plexus, and then it travels from this area through what's called interventricular foramen into the third ventricle. Okay, the third ventricle, as you can see in the red, this is the choroid plexus, also has choroid plexus, so it also has a significant CSF production as well. Okay. From the third ventricle, it then empties down what's called the aqueductal duct, which is down this way. As it travels down the aqueductal duct, it reaches into the fourth ventricle, which also has a choroid plexus, so there's also CSF production there. This is an area where there's CSF right next to the brainstem, as well as the cerebellum. The fourth ventricle can then leave. The CSF can leave via three main passages. The first one is called the foramen of Luschka. Okay? The foramen Neurological is right in the lateral aspect, so there's two of those. And then there's a foramen Magendi, which is only one, which is midline, which goes posteriorly. Once the CSF exits into the subarachnoid space around here, it then suspends the brain with CSF plus the actual subarachnoid space, and also travels downwards into your spinal cord and bathes your spinal cord as well. So when you're looking at spinal cord CSF, when you put in a spinal in somebody and you drain that fluid has actually been produced inside the ventricles of the brain. Okay? And it's actually now traveled all the way down to the spinal cord where you can actually sample it. So if you have somebody that has had a subarachnoid hemorrhage, okay, and you do a spinal tap on them, you should expect to see blood. Okay? Then we'll talk about that a little later as well. Okay? But eventually the CSF has to be reabsorbed somehow, and where the reabsorption is taking place is up at the arachnoid granulations up here in the top of the brain, and then it's being reabsorbed and gets back into the system. The normal hemostatic mechanism is to control the CSF to be a certain volume at all times. There's certain conditions that will make the CSF production to increase. Things like caffeine actually increase CSF production. Things that elevate your blood pressure and increase your CSF production. Certain kinds of all-time anesthetics tend to increase your CSF production as well. This is a normal passageway that you're looking at. Here's a lateral picture of it, showing the actual passage to the lateral ventricle, third ventricle, aqueduct sylvis, okay, aqueductal duct, going to the fourth ventricle, and then the Luschka, and then laterally and Magendi, and then going down to your spinal cords. Okay. And this is to show you more of a three-dimensional image of what the actual ventricles will look like. Okay, so these are pretty important structures when we actually have to put in drains. We'll talk about this in trauma again. The surgeons, what they do is they either use it stereotactically, or in trauma cases where you don't have the time, we'll actually put a ventricular drain based on location where the surgeon thinks it's at, and you'll actually penetrate a catheter all the way through from the skull all the way into the lateral ventricle, and then drain fluid out of the CSF to decompress or decrease the ICP pressures. As you can imagine, when you're putting in a catheter like that through the brain itself, it's going to cause some brain damage. But at that point, usually it's pretty important to get the pressure down, because otherwise the person's going to pass away from you anyway. So you might as well do something. Okay, so one of the things that we can do effectively is decrease CSF so we can give a little extra space, especially in the adults where they have a lot more CSF volume. This is a much more viable therapy. Okay? In children, it is much more difficult. Okay? I had a young boy one time that developed what's called amoebic encephalitis, and his brain began to swell very rapidly, and we actually tried to put a ventricular drain in him. It took us about half an hour and about 7 attempts to finally hit the ventricles. Okay? And that's pretty rare. Most of the time the ventricles hit on the first try. And we then gave amphotericin B through inside the actual ventricle itself. Now, what you see in children is the volume is so small that it's actually very technically difficult to insert these catheters. So the treatment is a little bit more difficult with brain injury of children in comparison to adults. Now, every once in a while you'll get some kind of disease process where you'll get the aqueductal of sylvis to be obstructed, okay, or will develop what's called stenosis, which it narrows. And what happens in these children is that the CSF that's being produced in the ventricles cannot leave. And as a consequence, you'll see the kid will develop hydrocephalus. Okay, so this is what you'll see. The ventricles become hydrocephalus. In children, because their brain is not completely, their skull is not completely closed, the actual bone is not knitted, the actual brain, the skull will actually begin to expand. So you'll see that these children have very large heads, which is what keeps them alive. Had they not had that, then the hydrocephalic pressure would have compressed them and caused their death. A lot of times what you see in these children is also they have associated seizures and they have a certain degree of mental disabilities. Aqueductal stenosis is by far the most common cause of obstructive hydrocephalus, okay? And it leads to an enlargement of the lateral and third ventricle and leads to an increase in ICP. CT scans are really very helpful for diagnosis. There's a big concern, of course, in children anytime you do a CAT scan because it is radiation, so they're using a lot more MRI. I can tell you MRI is not easy, though, either on children. If you ever had an MRI scan, you know how difficult it is to sit in that scanner when it's making that much noise. One of the things that they're starting to do is they're beginning to develop, they actually have it up in Fort Myers as well as up in Tampa. They have video systems where the patient can actually put on goggles and ear, so they actually watch a movie while they're inside the MRI scanner. But still the noise is tremendous and they'll still hear it. The treatment that you'll see is that we'll do what's called an intraventricular drain. Sometimes we'll do what's called a VP shunt in these kids, which is what's called a ventricular peritoneal shunt, which means you can insert the catheter through the brain, and then you take it and go down through the skin, down to the neck, and then you pass it all the way into the peritoneum. Okay? The other way we also do this is now, which is a little more advanced, is called the VA shunts, which is a ventricular atrial shunts. And what they'll do in these kids is they'll penetrate into the internal jugular vein and put the catheter in the superior vena cava or portions of the right atrium. And they'll actually have pressurized, they have specialized one-way valves that allow the CSF to drain downwards. Okay? That way the blood doesn't come back up into the brain, which would be catastrophic. That's why the initial one was done with VP shunts, because there's no, you're just letting the CSF drain directly into the peritoneum, and there was no back pressure from blood flow. But the new way is proceeding more towards the VA shunts. The other thing that their neurosurgery is really becoming a little bit more advanced is they're actually doing a new thing called aqueductal stents. This is a little bit high risk right now, and they're getting better at it. And what you do in these kids is you put them to sleep under general anesthesia, and they put these kids into what's called sitting craniotomy position, which we'll talk about in a little bit. And then they'll actually take a fluoroscopy device, basically it looks like an intubation bronchoscope, but it's a specialized scope that's got a little camera at the end of it. It's a really, really fine fiber optic cable. And they pass it up through the foramen of Magendie, and they pass it up into the fourth ventricle, and they can actually visualize it on a TV. So they can actually see the entrance of the aqueductal duct. And then what they'll do is they'll take a wire and thread it up through the aqueduct and do x-rays while they're shooting all this stuff. This is high tech, to say the least. Okay? Once they have this, they see where the wire is inside the third ventricle, then they'll feed a stent up and they'll deploy the stent inside the aqueduct. And these kids all of a sudden then are relieved of this obstructive process, and the hydrocephalus gets better. Now, as you can imagine, this is not a low-risk surgery. Okay? When you deploy the stent, the brain tissue that's around it is going to get compressed. And what's that brain tissue around there? Brainstem. You're looking at pons area, so it could affect the motor tracts. It can affect different things that may be very detrimental. There's a lot of argument if this is going to be effective treatment. It might end up working out okay. So I got to wait out and see how this plays out. I can tell you that there's the actual number of intracranial procedures that we're doing compared to what we did 20 years ago has almost reduced by about 70%. Okay? It's not that people are having less cancer or anything like that. It's that many treatments that we had before are basically being done other ways. One of the things that we find is anytime you want to instrument the brain, usually bad things happen. Okay, so avoidance of instrumentation of the brain is the more important things. So indirect methods of management like gamma knife, okay, radiation seem to be sometimes better treatment modalities than what we used to do in the past. If you have another possible problem called benign intracranial hypertension, also known as pseudotumor cerebri, what the characteristics of the disease process is that you have an elevated in ICP of pressures of greater than 20 millimeters of mercury. When you actually draw the CSF and look at it, the CSF looks normal. There's really nothing abnormal about it. There's no protein increase or anything like that. And when you do a CAT scan, you don't really see anything that would make you think this person would have an elevated intracranial pressure. There's no intracranial lesions. There's no stenosis of the aqueducts or anything like that. What you do see in these kids is, or even adults, and what happens, is you get sometimes normal sensorium, but most people start complaining of headaches, and then they start getting bilateral visual disturbances. Okay? We also tend to see this more in women, okay, that are obese with irregular menstrual cycles. The reason that you're seeing it with obesity and increased irregular cycles is that the increase in intracranial pressure begins to affect the pituitary gland. So these people start not releasing enough gonadotropin into their bloodstream. The good thing is that most of the time this is prognosis is good. Usually can be treated conservatively without too much of a problem. Treatments basically sometimes removing 20 to 40 cc's of CSF at a time. The other thing that's been done is you can give these patients acetazolamide, which decreases CSF production. And the worst case scenario, when things are they're having to have recurrent CSF removals. Usually sometimes you can just do it off for about 5 or 6 times and the person then sort of gets re-equilibrated. But sometimes there's no real improvement, so they'll do what's called a lumboperitoneal shunt. And what they'll do is they'll put a catheter into the subarachnoid space at the lumbar level, and then they'll drain it directly into the peritoneum. There's only one problem with this thing, is that eventually, anytime you put a catheter inside anywhere, you will tend to get fibrin deposition, protein deposition, and the catheter will eventually occlude. Okay? This includes the BP shunts. All these things eventually fail because the CSF is not a completely clear water. It has protein in it. And what the body tends to react to when you have foreign bodies inside you is that it tries to attack it. It begins to believe that it is a foreign substance. So even under perfect conditions, these things eventually do fail. Okay? The only time that we usually do these lumboperitoneal shunts, I've only seen it done once, is when the person's vision begins to deteriorate. The reason this is also important for you to know is sometimes these women come in afterwards and they get pregnant, okay? And then they'll come in and they'll tell you, well, I want to have an epidural. Well, I wouldn't do an epidural and I wouldn't do a regional spinal on this, specifically not a spinal. Okay? The reason not a spinal is because if you inject a local anesthetic in there, it may go right into the peritoneum and you don't know where it's going. You might not even work. Okay? The other thing is you might hit the needle onto the shunt. That would be a problem. Okay? The other issue is if you put an epidural in, will it work? And the answer is it may not work because you may have a lot of scar tissue that's developed after surgery. So you don't get the segmental distribution that you should get with an epidural. So for me, I think it's relatively contraindicated. I personally don't manipulate anybody's back that has these things in. We had to actually have this problem about a year ago, and somebody asked me, should we do this? And the books say, well, maybe you can do it. My answer to it is I'm conservative. I say to people, look, you know, you can do other forms of therapy to control pain during labor. It's not as effective, I know. But do I want to have a complication on my hands, including a complication the patient has to live with for a long period of time? The answer is no. Okay? Because you're doing epidural for maybe 24 hours pain relief for less, and this is a lifetime of disease process. If you mess it up, they're going to have to go back for expensive surgery. It's not worth it. So, at least in my eyes. That's my 5 cents on that. The other thing you'll see is sometimes people will develop what's called normal pressure hydrocephalus. And what you'll see in these individuals that have super large ventricles, you can see right here, the ventricle is absolutely huge. Okay? They have normal to decreased CSF pressure. The bad thing about this is that what they don't tell you about this is the reason that the pressure is low is because the volume has expanded into the surrounding brain. So the brain, basically, the brain tissue has died away. Okay? And that's pretty significant because it's more likely to lead to dementia, Small cell cells would lead to gait disturbances and urinary incontinence. So these people can come in very, very impaired. What's rather interesting about this is that otherwise it's hard to pick up. You think the person just has dementia, but otherwise there's no real signs of elevated intracranial pressure. Pretty much when you see elevated intracranial pressure, you see headaches and seizures. Those are pretty high in your list. And if you don't see that, you're going like, well, what is going on? And you get a CAT scan like that, and you get something like this horrendously, and you know this is not something that's going to be a good outcome. Even when you put a ventriculoperitoneal shunt or ventricular atrial shunts in these individuals, they don't really come back fully. They do improve. Sometimes I've seen the dementia reverse considerably, but not completely. Okay, so we don't know what really causes this. It seems like a more of a spontaneous, rapid degeneration of gray matter that takes place in these individuals, but as to why that happens, it's really unclear. Now, the other things that you are going to encounter over time in this job is that you're going to be asked to deal with intracranial tumors. Part of your neurosurgical rotation is you're going to see a certain degree of neurosurgical treatments of intracranial tumors. Like I said, most of these, if they're more of the astrocytomas and things like that, they can be treated with radiation, have moved towards that direction, seem to be more effectively treated that way than doing these big bulk resections that we used to do. The types of intracranial tumors can be basically based on tissue, which is by far is the most important in the sense of telling you long-term prognosis. The primary tissue that you, of course, have in your brain is neural tissue, which is, of course, your nerve cells. Then you have supportive tissue that actually are there to hold the neural tissue in place. And then you have your vascular tissue. So those are the ones that are going to either form tumors or become malignancies. You may also have metastatic tumors that will penetrate the blood-brain barrier. These are rare. There's only basically two that are the major culprits, which is breast and lung cancer. They're the ones that are the most likely to penetrate through the blood-brain barrier. Pretty much all the other cancers do not penetrate as well. Where you also see is some forms of leukemia and lymphoma will penetrate into the blood-brain barrier as well. Based on the location, you'll see supratentorial is more common in adults. They present with headaches, seizures, and usually with new neurodeficits. That's usually how they present. The infratentorial tend to be seen more in children, and the tentorium is this structure right here, which basically separates the brain from its actual upper cerebrum, and in comparison to the below the tentorium, which is the infratentorial, is where the cerebellum is at in the brainstem. Okay? So supratentorial tumors tend to be in more seen in adults. And the infratentorial, which is down the cerebellum and brainstem tumors, are seen in children. What they do is they tend to present with obstructive hydrocephalus, and they also develop an ataxia, which is basically an inability for voluntary control muscle movement that will take place. If you look at your primary CNS tumors, they originate from normal CNS cells. So you're looking at the nerve cells. You can also get commonly neuroglial, which are the surrounding supporting tissue. Things like astrocytes, which are important for forming the blood-brain barrier. They can go what's called astrocytomas. They also can develop what's called oligodendroglia, which form the myelin sheaths. These are equivalent to Schwann cells. The oligodendroglia are not very frequently causing malignancy as much as the astrocytes. And you have to ask yourself, why would that be the case? And I suspect a certain degree of the reason that is because the bloodstream is sending toxins into your body. Okay, when you eat things, your body will absorb it through eventually into the blood, and then it gets sent throughout your body. Okay, and within those, anything in contact with that blood that may have a carcinogenic element to it will cause that activation of cancer in those cells. So a lot of times when you see cancers develop in the brain, they develop as astrocytomas or astroblastomas. Okay? which are the supporting structures that are right next to the blood vessels. This is what actually forms the blood-brain barrier. So it kind of makes sense that that's really what's going to cause the initiating thing from a toxin or a virus. The oligodendrocytes, on the other hand, are more internally. So as a consequence, they're kind of protected by the blood-brain barrier. So they're not going to get as much this carcinogenic elements exposure. The microglia also don't really form cancers very often because they're just simply phagocytic equivalents. So they're usually not going to be an issue. Ependymal cells can cause cancers because of the lining of the ventricles and the choroid plexus. But again, these are more rare. Now, if you look at the differences between malignancy and benign, the benign ones are the ones that are encapsulated. And they can still kill you and still cause significant neurological deterioration if they're not removed. And basically what they'll do is they increase in their volume. They begin to compress on surrounding tissue. They'll cause an increase in ICP. They may actually cause compression of the blood flow next to the tissue, which impairs and causes ischemia, and may cause infarct, and it may also affect CSF distribution. The good thing about these primary benign tumors is they don't metastasize, and they don't tend to spread all over the place. In other words, the typical examples that we're going to talk about in this is meningiomas, which we take care of quite a bit of them, pituitary adenomas, astrocytomas, which are the non-malignant forms, but can still be difficult to handle, and then acoustic neuromas. Now, the meningioma is by far the most common form of benign brain tumor, and they can be located anywhere, all the way from supratentorial to infratentorial. They tend to grow from arachnoid cells, which is part of the meninges, and they are slow growing. And normally, they will begin to compress around surrounding brain tissue. The good thing about these things is they're completely encapsulated, so most of the time when the neurosurgeon opens up the skull and approaches it, they're able to cut off the blood supply and remove it intact. And these people basically are essentially cured at that point. And then they just need follow-up to make sure that they don't get any redevelopment of it, which can sometimes occur. The other thing that these things are sensitive to is hormonal things will change the tumor growth pattern in pregnancy because immunosuppression takes place in more. Tumors like this can actually grow very aggressively, and sometimes you will actually have to take these people back even while they're pregnant and take care of this problem. Okay? The other problem with this is it can erode into the skull itself, and that can become a problematic issue in the sense that you may need to have some titanium or other form of grafting of the skull after repair is completed. The other form of benign tumor is pituitary adenomas. Okay, they're basically located in the pituitary area, okay, which is right here. Okay, you can see it here. Okay, pituitary, and right here. And the pituitary gland this is a parasagittal cut, which is in front. Okay, and the pituitary begins to erode upwards as it becomes enlarged, and will begin to cause compression of the cross points of where the optic nerves are coming across. Okay, which is called a chiasm. So you get what's called compression of optic chiasm, which leads to what's called temporal hemianopia. That's how usually people present. They wake up. Usually they have headaches as well, but usually the presenting sign is visual disturbance, which is consistent with this. About 80% of these pituitary adenomas are chromophobes, which is a way of staining these tissues, and you can identify what kind of tumor it's from. They rarely tend to excrete hormones, and they cause what's called a panhypopituitarism, which means the pituitary just doesn't work anymore. So these people become problematic in having pregnancies. It's women. Their menstrual cycles go out of whack, and they tend to be infertile most of the time. The treatment is what's called transphenoidal resection of the tumor. It's actually we put these people under general anesthesia, and then the surgeon approaches the actual pituitary through the nose. Okay? So it's a pretty high-risk procedure, and especially in the old days, it was very high risk. But it's actually improving quite a bit because now we have three-dimensional 3D mapping. What they'll do ahead of time now is they'll do a CAT scan of the patient, and the CAT scan will then develop a 3D image of the brain, and then the patient will have probes put on them on the day of surgery to identify exactly the right location. So as a surgeon puts in a probe inside the nose, he can actually see on the CT scan image exactly where he's at and how deep he is. Versus in the old days, you just had to sort of look through the microscope and figure out exactly where you're at. So it's really made safety a lot more of an issue, and it's made things that are much more complicated a little bit more simplified in the sense of safety for the patient. Now, when you're talking about other kinds of brain tumors, such as astrocytomas, these are slow-growing tumors in the cerebral hemispheres. They usually will become malignant if left unattended. So surgical resection is pretty important, but it can be fairly difficult at times depending on its location. And when they also resect these tumors, they'll send them out for pathology, and they'll do what's called the grading system. If the person has a high-grade tumor, that's usually a bad prognosis because these things tend to convert into malignancies. The grading is based on tissue samples. The grade 1s are things called pilocytic astrocytomas or pleomorphic xanthoastrocytomas. If you go into grade 2, there's your low-grade astrocytomas. And then you go into the more serious ones that are more difficult to manage, which are the anaplastic astrocytomas. And the worst one to have is the glioblastoma multiforme, which is a malignancy. If you look at acoustic neuromas, these are tumors inside the cranial nerve number 8. Okay? It's a vestibular nerve, and it will actually cause compression and to the surrounding nerve and cause injury to the hearing. So these people usually present with unilateral hearing loss. They will start getting vertigo that's very severe. They'll get nystagmus, and as the disease progresses, it will begin to cause facial nerve palsy and numbness in the face. So it becomes a progressing disease. The big problem with this disease process is difficult to get to. Okay, so what has to be done is this is a pretty complicated neurosurgical procedure where you have to burr into the bone and eventually get to the acoustic neuroma to remove it. So it can be a pretty daunting procedure. Now, when you look at the malignant tumors, these are the glioblastomas and the medulloblastomas, are highly malignant. The most common of these is the glioblastomas. It involves the glial cells, which are like giant cell glioblastomas and gliosarcomas. They usually arise in the cerebral hemisphere, and they have extremely poor prognosis as they tend to be invasive, and it's very hard to resect these. The medulloblastomas, which is on the lower picture, tends to arise in the cerebellum. They tend to be in children, and again, they're also rapidly invasive, which makes them difficult to resect. Now, what do you do? What's the cause of these brain tumors? And it's really unclear. Some people think that it has to do with ionizing radiation. If your child has been exposed to a traumatic brain injury when they were younger, and then they were put through a CAT scanner, they said there's a higher incidence, there's a tenfold incidence of getting brain cancer. So that has definitely been one of those things that's been associated with it. The other thing that people think that is associated with cell phones, this is really kind of questionable. If that was the case, then some people that I know should have had brain tumors a long time ago because all they live with is the cell phones right next to their head. I would also tell you that I think it would be related to a certain degree with the skull thickness. So if you have a thinner skull, like in a child, I think you're going to have more exposure to some of this radiation, and you may have problems with that in the long term. The other thing that you'll see is that kids that are exposed to CRT screens may also have an increased risk of developing brain tumors as well. CRTs are the cathode ray tube screens, those big, thick ones they're actually shooting photons at the screen, and they go right to the patient, right to the person who's looking at them. Versus the The LED screens don't really do that. So if you have kids and you're worried about this kind of stuff, then buy them LED screens. They tend to be pretty cheap nowadays anyways. Diagnostic-wise, brain tumors can be diagnosed usually with CT scans pretty well. If you want to get more, the best resolution you can get with a CAT scanner is around 1 centimeter. So if you want more resolution than that, you need to get an MRI, which what's called an MRA, which will tell you the blood supply of the tumor, which can be important in some situations. And sometimes people are using PET scans as a way of picking up very, very small tumors that are metastatic, like breast cancer and lung cancer. Now, the brain tumor presentation is almost symptoms are indicating an increase in ICP. Usually, these people will present with new onset headaches, and they also come in with nausea, vomiting. If the ICP pressure is getting really worse, they'll develop lethargy and focal neurological findings consistent with like a stroke. Sometimes they'll just present with seizures. Because of the increase in intracranial pressure, if you look at their eyes, they're actually developing papilledema, and they have an increase in the systemic blood pressure to try to maintain blood flow to the brain. It's really not a good idea at that point to drop the blood pressure in these individuals. You want to sort of maintain it. Decreased heart rate can also be seen if the pressure gets too high. You get what's called a Cushing's reflex. And if you don't treat it or don't eventually manage it, it can lead to eventual herniation and death. Herniation, thank goodness, is a late sign, okay, but it's something you've got to start thinking about. And we will talk about this in more detail, especially when we talk about epidural hematomas and things like that. But one of the things that you'll see is that when herniation takes place, one of the first things that will happen is what's called uncal herniation, which is will cause compression on the optic oculomotor nerve, leading to a dilated, unreactive homolateral pupil, and which is a very serious sign. If you see that, you've got to start treating it immediately as a person that is herniating, and the immediate treatment is airway management and immediate hyperventilation. Okay, so as soon as you get them intubated and you start hyperventilating them. And then you take them to a CAT scan, get the definitive diagnosis, and then go to the operating room. Okay, this is where sometimes I've seen people in smaller hospitals, you'll hear that there's no CAT scanner available. They hear that somebody is traumatically injured. They think they're bleeding, and they got nowhere to run. The person's going, his pupils are dilated on one side, they're herniating, and they're going apneic, and they think the person's going to die, and then the person will do a life-saving procedure. It's a burr hole. And just put a drill into the head, drill it out, the blood will pour out, and all of a sudden the pressure gets relieved, and then they ship them out as quickly as they can to get it fixed. Okay? But at least that temporary relief of pressure will stop the herniation. If the herniation continues, it'll cause central herniation, or what's called cingulate herniation, which is the ventricle on one side will get compressed, and then will begin to push across. And then you can also cause, if you have skull fractures or any kind of weakness anywhere in the skull or any kind of hole in the whole skull, will cause transcalvarial herniation. The infratentorial is usually the ones that cause what most people are aware of causing death, which is the one that goes through the foramen magnum when you get tonsillar, cerebral tonsillar herniation. That's the last portion of the herniation cycle. The person will go apneic at that point, and will have complete loss of consciousness by a long way before that. So 6 is by far what you want to avoid. This is pretty much irreversible if you see that happen. Usually the brain is so compressed at that point that it's not going to recover very well. Treatment modalities is surgical resection of these tumors. So CT mapping is pretty important. We have a lot of modalities that we didn't have 20 years ago, including stereotactic biopsying, where we actually had 3D CT mapping. And if you completely resect some of the benign tumors, they're considered curative. If you have the other kinds of malignancies, then you'll go in for what's called gamma knife, which is a little bit better than we used to give, which was photon therapy, which is high-dose radiation to the brain. It would cause too much damage to the brain. Gamma knife tends to be selective, so you're able to basically see the brain tumor and get at it only, so it gets less damage to the surrounding brain tissue. Still, we don't really have a perfect treatment by far. And when you do radiation, you cause vascular ecchymosis to take place, and you can cause very significant brain edema to develop. So depending on how good the therapy and how big the tumor is, and how much gamma knife you're putting pressure on that brain, it causes problems down the road. The other thing that people are doing now is called brachytherapy, which is sometimes, we don't do that here, but some places like in Miami will do it. And also, I think up in Jacksonville, they'll do it as well. They actually put radiation beads right next to the tumor, and then they'll reduce the tumor size, and they'll come back and debulk it later on. Basically, chemotherapy is not very effective against most brain tumors because chemotherapy does not penetrate the blood-brain barrier. The way actually chemotherapy was usually done in the past and still is done into the brain is we put in what's called the Maya pumps. Okay, Maya pumps are basically devices. We put a ventricular drain in, and then we hook up a pump underneath the skin, and then we give the chemotherapy through the pump, and the pump cycles it in and puts it directly into the brain. It's a pretty big procedure in the sense that it's not really bad. It's not really that bad for the patient at the initial placement, but the chemotherapy can cause seizures and all sorts of other problems. But at that point, you have very little in possible treatments otherwise. So you try what you can. Neuromonitoring is pretty important. One of the things that we will do a lot in neurosurgical procedures is we try to monitor the brain as much as we can. What we do is usually we'll give a stimulus to the brain, and then we'll see the response that's occurred from the stimulus. These kind of tests are called the visual evoked potentials, the brainstem auditory evoked potentials, somatosensory evoked potentials. And then sometimes we'll actually cause an effect, which is a motor evoked potentials. That requires a probe or somehow stimulating the motor cortex and seeing the effects down at the motor units. Okay, so it's very different. Okay, most what we talk potentials are the evoked potentials are things that are coming towards the brain. Okay, so visual evoked potentials will be used for pituitary tumors. The eye will be open during the procedure and the light is exposed, and then you'll get a waveform that we can see the brain response, and you can figure out how much the signal is getting back there. The brainstem auditory evoked potentials is usually used for acoustic neuromas, and what you get in those situations, you send a certain kind of auditory signal, and then they'll see the waveform that's generated, and from that we can actually determine if the brain's getting compressed during the procedure. So these are ways of aiding the surgeon to get an assessment of the actual nerve function. Why is it important? Because anesthesia, if you use high doses of volatile anesthetics, you can suppress all these stimuli, and then it'll have the appearance that you have no more, that you've had compression injury. So one of the things you've got to be aware of is if they're going to do one of these kinds of monitoring, is you have to alter your anesthetic management to maintain a MAC of less than usually 0.6, and you have to use more of a narcotic, and sometimes you'll have to muscle relax these individuals so you don't have any issues. Where you cannot really muscle relax the individuals is in motor evoked potentials. So if you plan to use motor evoked potentials, you really got to keep the person without any degree of muscle relaxation. When we talk about spinal surgery later on, spinal cord tumors or anything like that, one of the things that we don't do is we don't muscle relax people during those procedures because we want to know if the surgeon touches a nerve, causes the muscles to jump. And that's something we don't want to paralyze and make the person sort of go away in that. Basically, tumors take up space, so they all eventually increase ICP. So management of elevated ICP is pretty critical. Medications basically that decrease ICP are things that you need to learn how to use. We'll also take CSF production and elimination and can have those consideration. You might have to put a ventricular drain in these individuals, or you might have to put in another form of drain. Ventilatory management, we'll talk about again in trauma about how to manage ICP by hyperventilation and what will happen, what's the downsides of it. The things that you do definitely want to avoid is hypoxemia, and hemodynamics is pretty critical of maintaining these people as stable. Almost everybody that has brain surgery should buy an A-line. Yeah, almost all of them. And almost everybody that has neurosurgical procedures has 2 IVs at the minimum because of positional problems. And in certain situations, which we'll talk about later, we'll put a central line in them as well. One of the things that you want to avoid if you put a central line is don't put it in the neck. You should need to put it in the subclavian. Why in the neck? Because you're affecting the blood flow of the internal jugular vein, and that could lead to problems of brain emptying of the venous system. So you really don't want to do that in somebody who was already impaired neurological function. Pre-op is, again, it's invasive monitoring. Blood pressure is pretty critical, so A-line is something that you need to consider. In brain injury patients or anybody that has any kind of brain tumor, I don't give them benzodiazepines. That's personally my choice. I've seen people get in trouble with 1 milligram Versed. The person goes apneic in pre-op, and that's pretty detrimental if somebody has already an elevated ICP. So for that reason, in my own experience, I don't use benzodiazepines. I try to just allay people's fears and talk to them. And I avoid using opiates again until I have a controlled airway. If you want to give anticholinergics and H2 blockers, these are considered safe in these people. It doesn't really cause a problem. Induction, when you're taking care of these patients, is you want to do a rapid induction where you immediately are able to control ventilation. Because key of this is ventilatory control. You do not want to let the person get hypercarbic on you. The safe agents to use are barbiturates, which we don't have anymore, so it's usually not an issue. This is an old book, of course. Yeah. It's not really old, but barbiturates is not available. Propofol and etomidate. Etomidate, the only thing I'd be worried about if the person has seizures, etomidate may not be the best choice. Ketamine is really a bad choice by far, and benzodiazepines, because they take so long to kick in and they're so long acting, they're really poor choices. Okay? So really the only choices you really have is etomidate and propofol. Neuromuscular blockers, you need to achieve rapid muscle relaxation. Should you use succinylcholine? The answer is a person paralyzed at all? If they have any kind of paralysis, then succinylcholine is contraindicated. You will get a hyperkalemic arrest on your hands if you have that situation, so you need to avoid it for that reason. But if you have somebody with a full stomach and you have some kind of traumatic injury that's recent, then succinylcholine is perfectly appropriate because you need to intubate these people rapidly. Airway by far takes precedence over everything, so you have to keep that in mind. Okay? And pretty much as soon as you intubate, you are going to increase ICP pressures. I don't care how good an intubator you are going to cause enough sympathetic stimulation to cause an issue. Okay? Place monitors and consider invasive blood pressure, which is almost I do that. I give an A-line to all these patients. Pre-oxygenating is critical. I always check my end-tidal CO2 prior to induction in these patients because I don't want to have, after I put them to sleep, that the CO2 is not working. It's not work. You want to have rapid control and you want to have rapid monitoring of CO2. You have to make sure that your airway process, decision process is well thought out before you start, because you don't want to lose the airway on these people. They're not going to tolerate it. If you let the CO2 build up, they may herniate on you. So you really need to have good airway management thought process beforehand. Pick the appropriate induction agent, a neuromuscular agent. If not doing RSI, immediately hyperventilate to a PCO2 of near 30, which is an end-tidal around 26. Okay? Remember, the end-tidal CO2 is always 4 to 5 below the value that you want to be at. Okay, so you're doing what's called mild hyperventilation at that point. The only downside of hyperventilating is what? You're going to get hypotensive. Okay, so be careful with that. You got to do a little bit of watching both. Okay. Then you what's called ameliorate airway reflexes. What I tend to do is I will start the volatile anesthetics during the induction if it's going to be prolonged to get to intubation, just to make sure that I'm suppressed enough and controlled so I don't get this really rapid hypertension after we intubate. Sometimes we'll use lidocaine. A lot of us will use IV lidocaine, about 1.5 milligrams per kilo. This seems to help. What IV lidocaine basically does is suppresses the brain function, plus also decreases the reflexes. And a lot of us will actually use LT lidocaine. I tend to like that because once you get them moving along in the case, the patient is comfortable with the endotracheal tube and doesn't really buck as much with it. And you need to diminish your time to airway manipulation, which means you've got to do it fast. Most neurosurgical rotations require that you're already a junior or a senior. So you've already have pretty comfortable with intubating skills, okay? Because you just can't be playing around with these people. Upon intubation, you want to assure proper intubation. You always make sure you have your end-tidal CO2. Then you try to achieve an end-tidal CO2 around 30 millimeters of mercury. If you think the brain is tight, then you drive them down to an end-tidal CO2 of 25, which in essence is 30. This one's a CO2 of 34, if you look at the blood gas. You avoid PEEP, because it decreases venous return from the brain, and it may increase ICP. The other thing I'm very careful about is make sure that the head stays straight. You see every once in a while, you'll see people that are traumatically injured after they've got C-collar off, okay? Is that patients are allowed to have their head flexed to one side. That's really, really bad, okay? You always want to keep the head midline to get good venous return coming out of the brain. So you got to be really kind of crazy about that. You see patients come up with C-collars are off and they're considered stable. During the whole case, what we used to do is you take 2 towels, roll them up, and put them along the ears right against the head so the person would not rotate to the side when you put them in different positions. Okay, because you are going to take the patient and rotate them depending on the surgery that they're having done. And that rotation will allow the head to rotate, and then you'll get occlusion, and then that portion of the brain will actually get edematous. You'll get a hemispheric edema, and the other side will be okay. You'll have a person will wake up that looks like they have a stroke. Not something you want to do. Commence your isoflurane, but maintain a MAC around 0.6. Okay, so you're going to lower MAC. If you don't have to worry about venous air embolus, nitrous oxide is considered safe, and it will actually help you with amnesia. So it's a good agent to use in combination. The brain is really one of those organs that doesn't let you play with very much. I mean, in the sense that you can make mistakes really, really quickly with the brain. Okay. When you have anybody with traumatic brain injury, you really want to maintain normal bulimia. Okay. You don't want to get them hypovolemic like we used to do in the past. Okay. The treatment in the past, if you had worked in this field 20 years ago, would have been to give somebody heavy doses of Lasix, heavy doses of mannitol, and essentially you were making these people really, really dry. And did that decrease ICP pressure? And the answer is yes, because your intravascular volume goes down. Okay? The downside to that is it limited perfusion to the brain. And if you decrease perfusion, what you end up getting next is ischemia. Okay? And with ischemia comes brain edema. And then it gets worse. It would usually take a 6 to 12 hour cycle to see this. I remember playing this, taking care of patients in the past, about 20 years ago, where you would try to see that their ICP was going up, so you would give them mannitol, Lasix, and do all this stuff, and immediately after you do the treatment, the ICP pressure would fall, and you feel like, yay, I've done my job, and you think everything's fine. 6 hours later, the person did it again. Now the pressure's back up, okay? And you're going like, what's going on? Why is the pressure coming back up? I mean, the brain injury shouldn't have gotten worse. But you do the repeat CT scan, and the edema has gotten worse in the brain. What we did not realize at the time, and still in a lot of places don't realize it, is that we were inducing hypoperfusion. And with that, we would get more edema, and then the person would continue doing the circling the drain maneuver for about 24 to 72 hours, and the patient would pass away on us. Okay? So new treatments are trying to maintain normal volemia, keep the volume stable, and keep the perfusion stable going to the brain. Okay? You really cannot play with blood flow to the brain. That's really is gone away. You really should not. You should try to maintain adequate blood flow to the brain. The only way to decrease ICP pressures in the modern medical area right now is to use ventricular drains or do something to decrease CSF. That's considered safe because the tissue can do fine without CSF, okay, as long as you don't cause herniation or anything like that, which can happen too. I mean, I've seen people do a ventricular drain. This happened about a year ago where somebody left the ventricular drain open and the person herniated. You can't do that either. Everybody's got to be taught on how to use this stuff. And I feel sorry for the ICU nurses that all of a sudden, a new neurosurgeon comes in, they've never played with a ventricular drain, And they were just told, here, you got to handle this. And the new surgeon, because he's been in a teaching center, has been doing it for 10 years, and everybody's got set up protocols, and everybody's been taught properly, you know, they think that everything's going to be fine. But when you have people that don't have experience, you can get really burned. Okay? So and the same thing's going to happen to you. When you get out to clinical, you have a new surgeon coming to town, and you'll want to do something different. And it's okay to be different, but you got to understand what he's doing and what he's trying to achieve. And anything that's invasive, like a ventricular shunt or anything like that, you got to really know how to play with it. Okay? And you're going to be doing this as well. I mean, if you're working in a trauma center, you're working with ventricular drains all the time. And what we used to do is, anytime we had somebody come into the OR with ventricular drain in place, we would ask what they wanted the pressure at. And the next thing we would do is take pink tape and cover the stopcock. So because we know invariably somebody's going to hit that daggone drain and flip the stopcock. So we would clamp it, make sure that there's no way it could happen by accident. Because we'd had other people where it had happened to them by accident, where something had opened up the drain and the person got, you know, symptomatic. They figured it out because the person got severely bradycardic, okay, which was an indication of herniation. They cut it back, and the patient came back. So lucky for that patient. So really, when you're talking about neurosurgical procedures, you want to maintain euvolemia. That's really critical. Okay? What I do is if you start seeing somebody losing a lot of blood, replace the blood, 1-to-1. I'm not a fan of giving a lot of crystalloids to patients because when they're bleeding. When you're talking about a disrupted blood-brain barrier, you're just asking for trouble. You're going to get so much edema in the brain that it's not a good outcome. I had one time, I'll never forget this case, where we were doing a very extensive orthopedic procedure where the guy had bilateral femur fractures and he had a traumatic brain injury to the patient. The orthopedic surgeons were taking a very long time. We've been at this for about 6 hours in the operating room. And this guy had an open skull fracture injury. And they started losing a lot of blood, so we started keeping up with giving fluids. Within about an hour after we gave about 2.5 liters of fluids, we had brain coming out of his ears and began to drip on the floor. Okay? And that's not a good day. Okay? My attending that was working with me that day came in. He looked at the patient. The patient was brain dead by his exam. And he told the orthopedic surgeon's game's done here, gentlemen. And we shut the ventilator off, and that was it. So you don't want to get yourself in that position. You just know that if you have somebody that's brainly injured, you cannot give a bunch of crystalloids to them. Okay? And you can't have surgeons working on somebody for 6.5, 8 hours, losing a lot of blood, and you're not keeping up either. You can't keep up with that kind of blood loss. Okay? So some things are just not fixable. And not to say that that guy would have died. If we did nothing, he would have died the next day, most likely, anyways, because he has so much brain edema. It was just not fixable. One of the things that you want to consider, too, is to give an adequate maintenance dose, usually about 1 to 3 cc's per kilo per hour. I'm not a real fan of going into the 3 cc's. I'm more like the 1.5 cc's per kilo per hour rate that I usually work with most patients. One of the things that I do avoid when I'm working with brain is that I don't give dextrose-containing solutions. Okay? They do increase cerebral edema because the dextrose penetrates into the brain and acts like an osmotic pump, and it sucks more fluid into the brain, especially in injured brain tissue. The other thing that dextrose will do is, because it's a primary source of energy supply to the brain, is it tends to hyperactivate the brain, and the metabolic rate of the brain goes up with dextrose. So as long as you're not getting hypoglycemic, which is what you want to avoid too, you want to keep a very tight glucose control. You don't want to give excessive amounts. Bolus therapy, I think, is very, very dangerous when you're talking about the brain, okay? Because the edema can form very quickly if blood pressure changes very rapidly, especially if somebody has a disrupted blood-brain barrier. So really, rapid changes in volume can really lead to rapid changes in ICP. And we used to be able to track that. We would watch it in the trauma bay. We'd have an ICP monitor in a patient. And when you gave a bolus to keep up with the blood pressure, because it was sagging, all of a sudden you see the ICP rise. and it was not a good thing. So we learned over time to don't get behind, first of all, stay even with a surgeon, and monitor. Monitoring was critical. So a lot of times people that were bleeding a lot, we put central monitoring, so we knew exactly what the volume was going on, so we didn't get behind. Maintenance for brain tumors is pretty critical in the sense that you want to optimize brain exposure for the surgeon. And you also got to watch for the neck veins. You want to make sure that the person has adequate venous drainage from the brain. You need to consider neuromuscular blockers in these people, and we would take them to the point that they would have 0 twitches. This is one of the few cases where I would tell you, you want to make sure that that person has no chance of moving. Okay? Because if you're working on a microscope and the patient coughs, it can be catastrophic. Okay? Especially when you're talking about aneurysm or repairs. We will have nitroglycerin and nitroprusside available, but really use these with caution. You should have A-lines if you plan to use these agents, as well as if you plan to use neosynephrine to maintain blood pressure. You should immediately put an A-line in all these patients. Invariably, everybody that gets intracranial surgery buys an A-line in my book. I think that's that's a standard of care you should follow as well. Okay? Position concerns can be very significant. Yes? Good question. What he's asking is actually critical. There's been several reported cases in the literature where patients were put in sitting positions. And during the actual procedures, the blood pressure was maintained at 80/40. Okay? What the person didn't realize was that the A-line was put at the level of the chest, which is what you're all taught to put it at, right? Because that's the phlebotomy point. That's the point of where, you know that's the central axis of where the heart's at. But that's not what you care about. You care about what the brain's being perfused at. Okay? So if you have an 80/40 blood pressure here, what's up here in this person's brain? And the answer is like 60/30. Okay? So what we do nowadays is that if we're putting anybody in a sitting position like this, which is either called a beach chair position, is that we put the actual transducers and tape them right here. So they're at the circle of Willis of that individual. Okay? And I've had neurosurgeons, tell me, well, I don't want you, it's in the way. It says, I can't get to it. And my answer is, well, you know what, then we're not doing it in sitting position if that's the case. That's how adamant I am about it. Okay? I don't want to have somebody not wake up on me. And they've had cases they've had cases where the person was doing what's called deliberate hypotensive technique. And when they woke up the patient, the person was never to wake up, just completely out. And they couldn't see anything was wrong. They take these people for CAT scans. There's no mass lesions. There's no bleeding. There's nothing. But then 2 days later, they develop what's called hypoxic encephalopathy. Okay? The brain has become hypoxic. Not that the person's desaturated. It's that you've had no perfusion in the brain for a long time. And it only takes about 10 minutes of low perfusion to start causing damage. So it's pretty sad when you hear about these kind of cases because it could be avoided simply by putting the transducers at the level of circle of Willis. Okay, so make sure that if you are going to do hypotensive technique, make sure you put your A-lines at the level where you can monitor the brain. When you're doing different kinds of tumors, you have different positions you'll deal with. If you're usually doing supratentorial tumors, which is above the tentorium, of course, usually we do these either supine or prone. What we watch for very carefully is make sure that the person's not getting their head extended, or flexion is too excessive or too much rotation. Because if you get venous outflow obstruction, it can cause an increase in ICP. You can also develop a severe form of macroglossia with that, which means that the tongue begins to swell up. And then if you extubate those people, then they'll obstruct, which is catastrophic. If you see macroglossia post-operatively, do not extubate that individual. Just put their head back to center line. Give yourself 2 to 3 hours, and the edema will go away in the tongue. And then at that point, you can consider extubating them. If you're doing posterior craniofossal resections, which is in the back here, and then we do what's called a sitting craniotomy, which is a very high-risk procedure. Okay? The reason it's a high-risk procedure is twofold. One, blood pressure. Two, venous air embolus. That's the biggest concern as well. So one of the things that you want to look for is if you're doing a hypotensive technique, make sure you put your transducer at the level of the circle of Willis. If you look at your VAE increased risk, you want to monitor, and we'll talk a lot about that. The most important monitor by far, the most sensitive one, is the transthoracic pulse Doppler, which detects a very small amount of air, 0.25 cc's of air. If you have to say which one is better than that, is TEE, but TEE is not easy, and in the sense that you have to continuously monitor it on. And TEE is something you got to really be. What happens to TEE after you leave it on for a while? Let's see how many people know something about TEE. TEEs basically emit sound waves, and when sound waves hit tissue, it causes heat to be formed. Okay, and TEE, if you leave it long enough, will burn the esophagus. Not good. Second-degree burns. So what the TEE probe has in it is it has a automatic shut-off mode. Once the temperature gets to a certain point, the TEE will shut off on you. And of course, that's when you need it the most, usually, when you're monitoring. So really, TEE is really not an effective monitor. It's very useful to diagnose rapidly if you're having a problem. But to monitor, you need something like a transthoracic Doppler. Esophageal stethoscope is pretty high on my list. I would leave the earpiece in my ear because I can hear air bubbles or hear what's called a Millwall murmur. So you got to really be attuned to that. Okay. As for the right atrial catheter, it's very controversial. It depends on who you read. I personally think it's a waste of time. If you get to that point, you're in a bad place. And I've never seen right atrial catheters really work that much. Some of the reported cases that were done a long time ago show that it worked, and then everybody else after that has not shown that it made a difference. So prone craniotomy is another possible position for posterior craniofossal resection as well, which are safe. Now, what happens if you do have a venous air embolus happen to you? Okay, it means that the only way it can occur is if a venous blood supply is open to air. And it has to be above the heart for the air to entrain. All of you have taken out central lines, have you not? Okay. All of you should have been taught before you put a central line out to make sure that the person's head is at the level of the heart or below it. How many people were taught that? How many people were not taught that? Okay. If you weren't taught that, there's a possibility that you may have encountered an air embolus, especially for a cordis. Okay? And what will happen is, and I've seen this happen, I've seen people die from this. Okay, so it's not a joke. Okay, I've seen somebody have a cordis pulled out of their neck, and right when they pulled out the cordis, what did the person do? Okay, they sucked in air real hard. Okay? And now the cordis is so large, it's an 8.5 or 9.5 French, that the vein was open, and the person sucked in 40 to 50 cc's of air, and air locked themselves out. Okay? And it was lethal. Okay? Usually the person will immediately begin to gasp for air. That's when you know you're in trouble, because the gasping of air is an indication that the air has now entrapped into the pulmonary artery, and you no longer are getting any oxygen or the perception of oxygen. HPV goes right through the roof, and severe pulmonary hypertension occurs and induces a gas reflex. The gas reflex is so potent that it'll break through into general anesthetic. I've seen that. It's really freaky. You have everything going fine, all of a sudden you see the person start moving on the endotracheal tube and going, what the hell just happened? Okay? And you've got like one twitch, and they still break through that. It's pretty impressive. So you have certain procedures that, of course, that are high risk. The ones that are high risk are more the head and neck surgeries, which is, of course, the neurosurgical procedures. That's where you hear it about the most. But where the other places where you'll see is all the other ones, liver lacerations, vena cava lacerations, All these can actually cause problems. I actually saw a venous air embolus from a patient who had a DNC. This is not I saw it, but a friend, the mother talked to me about it, and I told her what happened. Her daughter had done a DNC with thermal ablation. And when they do thermal ablation, if you ever see it when they're doing it by watching the actual camera, you'll see bubbles rapidly coming out. The thermal heat is so intense that any kind of air inside the liquid, which is water usually, will boil and will form air bubbles, and that will go through the pelvic veins and come back to the brain, come back to the heart. And they didn't pick up that she had a VAE. They did pick up that she had a stroke post-op. Okay, she was very weak on the left side. So she asked me what to do. I said, well, you call right now and tell them to put them on 100% oxygen and get them in hyperbaric chamber. Well, they put the 100% oxygen and the actual air embolus resolved within 10 minutes, and she woke back up. Okay, so what happened was she had what did she have? She had a PFO. 20% of the population has a PFO, patent foraminal valve. Okay, so when she get the VAE, instead of going to the lungs, it went across into the left side and then embolized to the brain. You've got to think. That's why this job is so dangerous. It's not simple. Okay, when you see something strange happen, you've got to think of all the possibilities. Immediately, who was a guilty party? The person came out with a stroke, and who's guilty of that? It's anesthesia's fault, of course. We cause a stroke. Yeah, anesthesia causes strokes. Yeah, everybody we put to sleep wakes up with a stroke. That is ridiculous. Okay, so you got to start saying, okay, what is the possibilities? Okay, possibilities of a stroke, which we'll talk about later. Hemorrhage, thrombotic events, embolic events. Okay, you look at the procedure you're doing. What is a possible emboli? Did we just do a bunch of femur repair? Did we throw a bunch of fat everywhere? Does this person have a PFO and it got across? Does this person have air somewhere? Okay, which is what this DNC procedure did. You can get the same kind of procedure done from head and neck surgery. Now, once the venous air embolus does is it goes into the right atrium and the right ventricle. If it's large enough, it will cause an airlock. Okay? And by an airlock, I'll show you a picture of it in a minute of what it actually looks like. The ventricle will be pushing against the air, and it can't push blood out of it anymore. And the patient dies right in front of you. Okay? The way they usually will present is they'll get tachycardic, okay, just like a normal like a PE. They'll get tachycardic if they maintain. Okay? What you'll see is if it transfers to the left side, you'll get embolic phenomena going to the brain, but also may go into the coronaries, and then you may have an infarct, coronary infarct as well. Bad, bad, bad. Detection is pretty critical, so Doppler transducers will be the most sensitive. TE is helpful, but it's really not a good monitor for this kind of problem. End-tidal CO2, we'll see a rapid decrease. This is secondary to increases in dead space and increases in areas that are being ventilated but not perfused. So this is dead space. And you'll see also, if you're lucky, if you have end-tidal nitrogen, you'll see it jump up. Because nitrogen is not something you're giving during the case. Nitrogen is basically air. Okay? So if you get air from the environment, it'll pick up as a rapid increase in end-tidal nitrogen. Okay? Do we have that here? The answer is no, but in a lot of the places they do monitor end-tidal nitrogen. So methods of detection, I think by far the best one is going to be your precordial Doppler. Okay? It has high sensitivity. It has moderately availability, and it's non-invasive, which is kind of a nice. The limitation is in obese patients. This is actually a study done it's a review article. If you want to read this, is a great article in anesthesiology, volume 106, number 1 in January 2007. This is a whole review on VAE. It's very, very well written. So if you want to read this when you get to clinical, especially when you're doing sitting craniotomies, you can actually bring the article in to the people you're working with and sort of share that with them. And it will actually very much commence a good discussion Because if you've done this enough in the clinical area, you do know what VAE is. You do know the risk of it. So to have somebody else bring in a review article and show it to the proctors may actually stimulate some discussion. They can tell you about what happened to them. And hearing stories is how we learn. Humans don't learn just out of reading. Most of the history of human beings is learned by listening at the actual fireside of a story about what happened when the bear came at us. Okay? Or what do we do with elephants? How do we deal with them? Okay? We still learn that way. That's why we communicate so much by talking. That's why we lecture. Okay? So try to learn from other people that way. It's actually easier and it's actually more entertaining. So if you look at the other ones that are least sensitive, saturation is pretty low in sensitivity. Usually that's very late. And EKG is also very late. Okay? So these are late changes. That's where you don't want to see. What you see is a gas reflex, which I already told you about. This is an actual study done on dogs, and what they did was they gave air to the dogs, and then they showed the mapping. This is the ventricle, the right ventricle, when it's got blood in it, and this is what it looked like afterwards when they got air in it. Okay, and you can see that the ventricle basically cannot move air. This is the CT scan. This is a bad CT scan because this person most likely did not survive. You see how much air is inside the ventricle? Okay, not likely this person's going to do very well. Okay? Now the question is, what do you do when you get this air trap? And some of the literature says, well, you can put a right central line catheter in and aspirate the air. Excuse me. Yes. Okay. I've never seen anybody do it effectively and quick enough. Okay. Because usually you have seconds. Okay, so you're not going to do it. You're not going to gown up, put in your invasive line, and suck out the air. You're not going to save anybody that way. Okay. What actually does work is do chest compressions. Chest compressions work to push the air through. The first thing you want to do, which I'll talk to you about the steps that you go through, just prevention by far. Prevent the occurrence first, and monitor early. Do not let it get to the point where you're hearing the mill wheel murmur. If you're hearing a mill wheel murmur, you're really late. That's catastrophic VAE. Okay? Yes? Okay? That's what it actually sounds like. Okay? It sounds like water going through a mill. Okay? So it's you'll never believe it until you hear it. Okay? I've heard it one time and hope I never hear it again. I had my esophageal stethoscope listening. And we got out of it pretty quick, but it was the guy got hypotensive for a few seconds and it resolved. Because we treated it pretty aggressively. Okay? So really, the esophageal stethoscope is key on doing this. The Doppler is really kind of cool because as soon as the Doppler starts hearing the murmur, the surgeon reacts right away. They always, when you say to them, I hear a murmur, the surgeon looks at you like, yeah, right, you know? And they keep working like it's nothing. You got to tell them, flood the field. Okay, versus the Doppler, I think, is a little nicer because you hear it. You hear the little bubbles coming through. And the surgeon will then immediately begin to look and find where the actual the sinus is open and close it up. Okay? The lethal dose for most air emboli are 3 to 5 cc's per kilo. If you're using nitrous oxide, it can be as low as 2 cc's per kilo. So if you think this person has a very high risk for VAE, I would not be using nitrous oxide. Okay, or at least not. Once you get a VAE, don't restart it. Shut it off and go to 100% oxygen and make sure that it stays off. So here's what you get. Source is air entrainment. Okay, it could be from venous channel or pulmonary circulation. It goes to the right ventricular air channel. You get small, medium, or large. Okay, there's an entitled nitrogen.
You get the oxygen desaturation, altered mental status, and wheezing. If it gets more than that, you get all these symptoms. Plus, you get breathlessness, wheezing, pulmonary hypertension, ST segment changes consistent with right ventricular hypertrophy, right ventricular hypertension. You get jugular venous distension from failure from blood returning back to the atrium.
You can get ischemia, mental status changes, and then you can get into a complete right heart failure and complete cardiovascular collapse if you get above 2 cc's per kilo. Treatment is immediate telling the surgeon, flood the field. That's your number one step. Prevent any further entrainment of air. Okay, so you got to tell the surgeon, flood the field, you got air coming in. Okay, and then what you should consider doing is if you can, put the head below the heart, or at the same level as the heart at the minimum, if you can do it. Sometimes in neurosurgical procedures you can't. You really can't. So you're stuck because leaving the position of the patient where it's at. Some people will actually do transient jugular venous compression. I think it's also ballsy to do that because invariably you're going to compress on the carotid arteries and then you can really get into trouble. So I'm kind of careful with that. Okay, I instituted immediately, if that was the case, high flow oxygen, shut off your nitrous oxide. Then you reduce the embolic obstruction by, some people will tell you about the Durant maneuver where you put the patient into a left lateral decubitus position. All the animal studies have shown that it's an absolute waste of time. It made absolutely no difference on the animal studies. So still people who will tell you to do it? Yeah. Okay, so you'll do it. Will it help really? Not likely. Okay. The bad thing about putting somebody in left lateral decubitus position is what? You can't do chest compressions. So that's what I'm telling you. I don't think it's really a good idea. If you really need to, if the book, if they ask you in the test question, what's a first maneuver you should consider of, and it's really an old question, then left lateral position may be. But the recent stuff that's coming out is saying that the animal studies is useless. But what does work is chest compressions. So if you have a choice, chest compressions or left lateral decubitus position, chest compressions. Go right to it. Okay, especially the person's resting on you. Sometimes people will say put them in Trendelenburg head down, which is a good idea because you basically stop the embolic phenomena from getting worse. But really, CPR and chest compressions do work. The aspiration of air from the right atrium has really very, very poor success rates. Okay? And if you really read the original article, and everybody, you know what kind of central line people put in for these things, and they think they're doing the right thing? They put in quad lumens. What a joke. Okay? The original catheters that were put in to prevent VAE are specialized catheters, and they have large bore holes in them, so you can aspirate air. Okay? So it's not a joke. Okay, these are big, big catheters. So if you expect to do that with a central line, which is in the superior vena cava, I don't think it's going to happen. Okay? If the air is already in the ventricle, it's not going to happen. You're not going to pull the air out of the ventricle. You've got to do it by chest compressions. Okay? Hemodynamic support is usually indicated giving ephedrine and some other things, and then some people will put them on hyperbaric oxygen therapy immediately post-op or right at that point if they can get them into hyperbaric chamber. If you have somebody develop a VAE that's significant and you have a TE, I would slip a TE probe in right away, and that would give you an indication of how well your therapy is going. Okay? Because then you can see the air inside the ventricle. As you're doing your chest compressions, you'll see that it empties. And sometimes chest compressions can be a little bit more aggressive than you're going to want. I mean, you want to have more aggressive chest compressions in some people, just to get the air out. Once the air gets into the pulmonary circulation, it will be diffused out through the lung, through the alveoli, and out through the mouth. And usually does not cross all the way across the left side. It's very, very unusual for that to happen, unless you have a PFO. And if you have a PFO, then you've got a person who's going to embolize the brain, and you got a big problem. So 100% oxygen is the deal at that point. Anesthesia management for these kind of cases is emergence. Is that you want to make sure the ventilation is adequate, and you want to avoid bucking and coughing. You want to reverse the neuromuscular blockade adequately. And really right away after you extubate these people is you want to do a full neurological assessment. And if they're not really responsive, don't pull the tube out. Just if they're not responsive at that point, you need to consider taking them to CT scan. Okay, you may have another problem that you just don't know yet. I had one case that was really interesting. We had craniotomy, brain tumor. The kid was like 18 years old. Put him to sleep. It's a benign meningioma. It was large. Okay, it took up almost a third of the left hemisphere. put that much compressive force on it. It was removed, no problems, okay? It seemed to be no problems. We woke the kid back up, and when we woke him up, he wasn't moving his, we did it on the left side, so he wasn't moving his left arm. Okay? That didn't make sense, right? Neurologically, if you're working on this side, it should cause paralysis on this side, right? So instead, when we woke this kid up, he couldn't move his left arm. So immediately we put him back to sleep, ran him down a CAT scan, okay? And what we did, when we looked at the CAT scan, he had a subdural hematoma on the opposite side. Okay, what happened was when they took the pressure off, it shifted the brain so fast that it actually ripped the veins in the subdural sinus. Okay, so the kid went right back upstairs, emergency craniotomy in that side, burr hole, removal of the blood, and then we woke the kid back up, completely intact neurologically, and went home 3 weeks later. That's how powerful this stuff is if you know why you do neurological exams when you wake people up. So when they're opening their eyes, you say move their arms and legs before you extubate them. Because the last thing you want to do is have somebody extubated now that's got neural deficits in your hands, and you've got to take them back to the CAT scanner. Because now you've got to do something. You've got to figure out what's going on. And the last thing you want to do is transfer somebody to the CAT scan and lose their airway. All right, so we'll talk about cerebral vascular accidents. All right. This next section is going to talk about cerebral vascular diseases that you'll encounter. One of the things that you have to be able to differentiate pretty quickly is if you have developed some form of CVA, which is cerebral vascular accident during the case or immediately following the case. And what you're seeing in these kind of accidents is a decrease in perfusion to the brain. Usually it's from a branch of the main artery, which is the internal carotid artery or the vertebral artery, that leads to ischemia, and eventually, if you don't treat it adequately, it can lead to infarct. There's two ways, actually there's three ways, which are called the RIND. Instead, I'm just going to cover TIAs and strokes. RIND is a level between a stroke and a TIA. That can last up to a month, but TIAs is what we use usually in the sense that it's something that's reversible ischemia that resolves usually within 24 hours. The bad thing about TIA is it usually indicates to you that you have an impending stroke and you need to really work this person up fully. If a person has developed a stroke, what happens is that the person's developed enough of an ischemic event that has proceeded to infarct, tends to follow vascular anatomy, and if a stroke can actually be non-hemorrhagic or hemorrhagic. The hemorrhagic strokes are much more dangerous and permanent because when your hemoglobin breaks down from inside the red blood cells, it deposits what's called hemosiderin in the brain. And iron is very detrimental to brain function, and it increases the risk of developing seizures that are long-term. Still, strokes are considered the leading cause of disability in the United States, and the third leading cause of death as well. What you see with strokes is that you can actually break them down into non-hemorrhagic, which accounts for the majority of them, which is 80%. And when you look at a non-hemorrhagic stroke, the most common is due either to a low perfusion state. It could be from also arterial vasospasm. It could be also from acute arterial or thrombotic occlusion. It could be from arterial compressive arterial occlusion. It could be from an embolic event. And you can also get a stroke from a venous thrombosis as well, because the back pressure will cause cerebral edema. Even though the blood supply is adequate, the blood has nowhere to go, and then edema begins to form in the tissue and then causes compressive problems with perfusion. On the other hand, hemorrhagic stroke accounts for only about 20% of the strokes. It's either from arterial or venous rupture, and also they can be classified based on position as either intracerebral or subarachnoid. Intracerebral means that the bleeding goes into the actual brain tissue itself. You will not see blood in the CSF in these individuals, versus subarachnoid hemorrhages are going into where the CSF is at. And some subarachnoid hemorrhages can be so severe that they will basically clot off the aqueductal duct, and you'll get hydrocephalus, which may lead to death. If you look at the non-hemorrhagic strokes, it usually follows cerebral anatomy, so you have to go back to the initial discussion which we had in the first semester, which is looking at the circle of Willis. Remember, the main blood supply to the brain is through 4 major arteries that arise from the aortic arch, 2 of them being the internal carotid arteries that come from the common carotid arteries, and then you also have from the vertebral arteries posteriorly coming to form what's called the basilar artery. Okay? Circle of Willis, of course, is you're looking at it directly here. This is internal carotid artery. When the internal carotid artery comes out and branches into the middle cerebral artery, which provides the lateral aspect of the hemisphere, and that's the area where the leg is at, and the anterior cervical artery is here. The way it actually the blood supply gets to it is through a branch, which is part of the circle of Willis, of the anterior communicating artery, which then binds and allows blood supply to go to the anterior cerebral artery. You also have a posterior communicating artery that attaches to the posterior cerebral artery that gives you accessory blood supply, in addition from the vertebral arteries, which is another portion of the blood supply. Now, what this system is made for is if you lose one of these arteries, the other artery is supposed to make up for the loss in perfusion and basically provide enough blood supply to the brain so it doesn't infarct. That's the purpose of the circle of Willis. So you sort of need to memorize this once again to make sure that you know where everything's at. Okay? What will happen if you get neurological deficits, if you get an anterior cerebral arterial occlusion, which tends to be rare in the sense of being isolated, will cause contralateral leg weakness, okay, because the leg is on the homunculus member is on the leg is on the inside here, the arm's out here, so that's more of a middle cerebral artery injury. But invariably, most of the time you'll see that somebody who has leg weakness and arm weakness is usually from the internal carotid artery has thrown a thrombotic event and has occluded both of them usually at the same time. So it's pretty rare to see an isolated infarct from anterior cerebral artery occlusion. Okay? Middle cerebral artery occlusion leads to contralateral arm weakness. Okay? It also gives you a hemisensory deficit in the face and arms more than the legs. And you also get aphasia if it's in the dominant hemisphere, and you'll get contralateral visual field deficits. If, on the other hand, you get a posterior cerebral artery occlusion, you get a contralateral hemiparesis, okay, and you get a contralateral visual field deficit as well. If you have some penetrating arteries, can actually cause damage as well. If you look at this as the middle cerebral artery, if you get occlusion and thrombotic events that come up in this area, it affects the thalamus and it starts affecting some of the white tracts that are leaving, so you get contralateral hemiparesis as well as loss of hemisensory as well. If you look at the basilar artery occlusion, go back. This is a basilar artery. Remember, it comes together from the vertebral artery. The basilar artery is right next to the brainstem. Okay, so it provides via pontine arteries in the anterior inferior cerebellar artery comes off the basilar artery, so it provides blood supply not only to the brainstem but also to the cerebellum. So you're going to get cerebellar and brainstem kind of neurological deficits. So when you get this kind of problem, you get basilar artery occlusion, you get oculomotor deficits, and you may also get ataxia and with cross-sensory motor deficits from cerebellar effects. If you get vertebral artery occlusion, it can then lead to basilar artery occlusion as well, which then gives you cranial nerve deficits and also the ataxia. What do you do when you have somebody who have a stroke? Is you do a full neurological examination to find where your focal findings are at to indicate to you which portion of the brain is being attacked. Do an immediate airway assessment to make sure the person is breathing adequately. Early airway intervention is critical. If you have somebody that's not breathing well, intubate them. Okay, get them airway secured. Because one of the terrible things that happens when you take care of these people is they can aspirate on you. A lot of times they've had a meal recently, and they'll aspirate on you if you don't get the airway secured quickly enough. Okay? It is a medical emergency, which needs rapid diagnosis, because ultimately the only thing that will save this person's life will be either perfusion to be reestablished, which sometimes will require thrombotic therapy, thrombolytic therapy. Okay? what this person needs is they need an immediate CT or an MRI. Most of the time we do CTs because they're so fast. MRIs will take anywhere between an hour to 2 hours to get a final actual diagnosis, and the person has to be in the tube for 2 hours. That's not a joke, especially if you're doing an MRA, which is a magnetic resonance angiogram, or you can also do an MRV, which is a venous scan. We're looking for like what's it called, a venous thrombosis. So the CT gives you a much more rapid diagnosis. Okay? If it's hemorrhagic, basically at that point, it's nothing you can do except evacuate the hemorrhage. So if you have a hemorrhagic stroke, the thrombolytic therapy is out. Okay? If it's normal, then really there's nothing else to do except figure out what's causing it could be vasospasm, which then you treat the vasospasm. If it's ischemic, on the other hand, then the next thing you want to consider doing is the MRA. Okay? Most of the time, if it's ischemic and it's really acute, they'll move right to treating with thrombolytic therapy. What this basically does is the MRA will then give you the further differentiation of what you're dealing with. Either that you have atherosclerotic disease, non-atherosclerotic disease, which is give you different diagnosis of either it's cardioembolic, vasculopathies, or coagulopathies. Okay. Carotid endarterectomy is something that if somebody has had a TIA, one of the things that they'll be worked up is for carotid atheromas, which is means that there's thickening inside the carotid arteries. And we find that anybody who has a 70% lesion benefits from a CEA, carotid endarterectomy. Okay? Anybody under 70% is controversial. Okay? So pretty much everybody you're going to see that comes in will have a 70% lesion or greater. Where I've seen where we've actually done a 50% lesion is somebody who has what's called an ulcerated plaque. And those people are very high risk for throwing embolic phenomena. And actually those people do benefit from doing a CEA on them as well. Okay? CEA is not without risk because what you're doing during that procedure is you're basically going to clamp the carotid artery and not provide any blood supply to the brain. So what some of the surgeons do is they'll do what's called a shunt. They'll actually take a plastic tube, a tubing, and connect it up to the lower portion of the carotid and then bypass the area where they're repairing and put it above, and that way they have adequate perfusion during the whole time. Not everybody does that, though. Okay? Some people believe that makes any difference. Some people believe it does make a difference. And the literature out there is really unclear, unfortunately. In the future, what we might be doing more of these is that we might be doing more angioplasties and stenting instead of doing these surgical procedures. Preoperatively, you want to do a full neurological exam, do a full cardiovascular and renal evaluation, because a lot of times, if you have carotid disease, you have heart disease. Okay? Anybody that has peripheral vascular disease, which means this is peripheral vascular disease, this is in a different area, then you have cardiac disease. Okay? And you may put some of these people to sleep and might find out that they have left main. That'd be a bad day. Okay? So make sure that you have a full cardiac workup before you do these patients. See what your arterial baseline blood pressure is. If the blood pressure is 160, this person should be maintained at 160 during the whole case. You really want to maintain adequate perfusion. So it's not appropriate ever to drop these people's blood pressures down. And surgeons usually will request you to maintain the blood pressure in the 160s, 170s during these procedures to maintain high perfusion rates of the brain, especially through collateral blood flow. Please do not palpate the carotid arteries. It's not a good idea. Okay? You can throw a carotid emboli by doing that. And is it okay to listen to the bruit? Yes, but just don't press real hard on it. Okay? Just put your stethoscope on it really lightly to hear the bruit so you know what it sounds like, so that way when you take care of somebody else, you can pick up on it, and but make sure you're not pressing on it. And just put your stethoscope lightly on the neck. How do you take care of these? And there's two ways of doing it. Some people like doing them awake, and I've done it both ways. I've done it awake, and I've done them under general anesthesia. Here we tend to do them under general, okay, which I prefer, to say the truth. The way we used to do them awake was we'd bring these patients up to the to the preoperative area and put the A-line in first. After we had the A-line in, we would then give the person a little bit of sedation to make them comfortable. And then we would proceed to do a two-step block process. The first block would be the superficial cervical plexus block, and the next one was a deep plexus block. Okay? The superficial plexus block, basically you take the needle, just look for where the sternocleidomastoid muscle is at, and you go mid-neck, and you just take your needle, put it in 5 cc's in one direction, 5 cc's in the other direction, and that's it. The superficial cervical plexus comes out in front of the sternocleidomastoid muscle and then gives the sensory innervation to the skin in this area. Okay? That will not be adequate for the surgery, though. That'll be adequate for the incision, but once they get deeper, the person will start feeling stuff. So it won't work. Okay? So that if you want to get the deeper level, then you have to do what's called a deep cervical plexus block, which is basically like the interscalene block. Okay? It's almost the same thing, except it's a little higher. Okay? So you're doing C3, C4, C5. So what are you going to knock out on this side? Diaphragm. So that's one thing you got to be aware of. When you're doing these awake, the diaphragm goes out on that side. So it's never appropriate to do an awake bilateral CEA. Just can't do it. Okay? Now, one of the benefits of doing it awake is that you can get continual neurological evaluation. And what you're doing is, if you're doing operation on this side, where are you going to put where are you going to look at for monitoring? Contralateral side. Okay, so what we would do is we would put a little horn on the person's hand, like one of those bicycle horns, and then every once in a while we tell them to squeeze on the horn. Okay, it's very strange. Okay, it was very irritating too. So some of us decided to make it a little bit easier on us because every time you hear that sound, you jump. So we put the rubber duckies in their hands. And it's not so bad. Okay, so that way you know that they were neurologically intact. Personally, I hate awake because what will eventually happen is when the surgeon puts a clamp on, the person will start doing this. Seizing on you? Great. You got the fields completely covered the face, and you're having a person actively seizing from hypoxia and ischemia. Really a bad place to be. And then you're having to push the surgeon out of the way to get the guy intubated in a terrible position. So I'm not a real fan of doing a wake one for that reason. I've had 3 of them happen to me and they seized. And after the 3rd one, I said to myself, when I get out in private practice, there's no way in hell am I ever doing this again. Everybody's going to get intubated from now on. And we almost lost. The last one we almost lost because we almost couldn't get him intubated. Okay? So it's not a joke. So that being said, the benefit of it is if you see the person completely awake during the whole procedure, they're going to wake up fine because they've been awake the whole time. So the surgeon knows that they didn't do any damage right away. That's a real benefit to it. The risk, though, to me, is pretty high. Losing an airway, having somebody actively seizing, just nightmarish. Okay? And then contaminating the surgical field to get the person intubated really makes the surgeon kind of unhappy. Okay? So. Now, the other thing that, what's the downside? What's the downside of putting somebody to sleep? There is a downside. You're now having somebody who's completely asleep, and you don't know what's going on in their brain. You don't know if they're developing ischemia. Okay? And so you have to go to high-end monitoring. EEG is almost like a waste of time. People will do it. But does it really make a difference in outcome? And the answer is very, very questionable. If you're watching the EEG, who's actually doing the EEG monitoring? It's a tech. It's not a doctor sitting there looking at it like, you have ischemia. You know, there might be subtle changes, and the person will say, I have some subtle changes. If you had somebody else reading it, they'd be jumping up and down saying, this is bad, stop. You know, so it really depends on your tech, and the tech's not allowed really to read it. Do you know that? Medical legally, the tech's not allowed to read it. They can infer, and they'll turn the screen to you and say, see? And you go, try to look smart. Yeah, clueless versus clueless, right? No. So, I mean, we're not really trained to do EEG readings. I mean, I don't spend 200 hours sitting in front of an EEG machine trying to read it. That's the job of a neurologist. Okay? And we don't have, one of these days maybe we'll have it, where the EEG will be sent to a neurologist's office. When the tech sees something, hits a button, the neurologist immediately comes on screen, looks at it, and says, you got a possible ischemia. Then I'll be impressed. Until that day, it's just nice little squiggly lines. Okay? What might be more helpful, which has been finding, is that you can do cerebral oximetry. Cerebral oximetry seems to help. It's not perfect, but it seems to help because it's monitoring each hemisphere for oxygen levels. And if you see the cerebral oximeter fall on one side, you tend to try to intervene more rapidly. It seems to be a little bit more sensitive. Is it a perfect monitor? No, there's problems with it. Okay? But it's something that may be something that you guys will become experts with in the next few years. I think if you're going to be doing this kind of procedures, I think it's the next thing to really consider putting on patients before. Because by the time you get EEG changes, what's really happened at that point? It's late. It's really late. EEG changes don't occur immediately. They take a few minutes. By that point, you're already getting ischemic. Okay? Now, the other thing is general anesthetics tend to be protective, especially isoflurane. Isoflurane protects the brain, so we tend to use that as our primary agent. The downside to it is you can't use a lot of it because then you affect the EEG. You can suppress the EEG so much with volatile anesthetics that you knock out the EEG reading completely. So you got to get your volatile anesthetics to usually around 0.6 to 0.8 MAC, okay, and just keep it there. You can combine it with 50% nitrous, not a problem. If you go higher than 50%, it starts affecting EEG as well. Sometimes we'll use fentanyl. It doesn't really cause a problem. But if you use benzodiazepines, you can screw everything up. You can make somebody isoelectric with benzos. So you got to be really careful about the drugs that you're using. Okay? The real benefit is that you now have a controlled airway. You've got the person intubated, and the person, even if they seize, they're not going to lose airway. Okay? The downsides is that you get delayed neurological evaluation, and you really need to do more monitoring. When you're doing CEAs, the goals are maintaining hemodynamics stable. Usually it means that that person is already hypertensive, so you want to keep them hypertensive. A lot of times we'll use a neosynephrine drip to do that. Okay? All these people need A-lines as a consequence. You want to achieve rapid awakening to make sure that you have a full neurological assessment at the end of the procedure. I've had surgeons yell at me if the surgeon is having to wait more than 5 minutes. So that's the level you have to get to. You should be able to extubate and have the person awake within 30 seconds of the surgery being done. And that's what your goal is. So that means you've got to learn how your pharmacology works properly, and you've got to learn these little different techniques on how to waken people up quickly, which we'll teach you. Arterial lines is, I think, if you don't have an arterial line, I think that's just stupid. You need to have an arterial line. PA catheter, I've never used. I think it's a waste of time for this kind of procedure. The reason I use PA catheters is for fluid shifts. Okay? There is no fluid shifts here. Okay? There is no large volume blood loss here, unless the surgeon loses control of the carotid artery, which is, at that point, you got a bigger problem. Okay? Which is a surgeon at that point. Okay? They should never have lost control of the carotid artery. Okay? It should be very well exposed before they penetrate it. So there's absolutely no reason they should lose control. I always have these people usually normal carbic. Okay? The reason I'm not going to hyperventilate them is I don't want to do what? Right, I don't want to decrease perfusion. I don't want to limit perfusion. So normal carby is where I want to be at. I usually will muscle relax these people to the point that they're relaxed, okay, and not going to move on me. So that's one thing I got to be watchful for. The other thing is that you can do monitoring via EEG. The stump pressures are done because you'll have surgeons that will ask you what the stump pressure is, which they'll actually take a catheter and give it to you, and you'll hook it up to your A-line, and you can actually measure what the pressure is distal to where they're cramping. Okay? You want to maintain a pressure around 50. If you're below that value, that's not good. You need, in that case, usually we'll put a shunt in. Okay? So some people say, well, 25 to 50 is where you need to be. I'm a fan of 50. If you get below 50, I think you're asking for trouble. Okay? So sometimes the surgeons will tell you, well, I don't want to shunt this guy, and they'll do the stump pressures and find out that the pressure is 25, and then they better put the shunt in. Okay? Transcranial ultrasonography, it's got problems. The cerebral oximetry seems to be better, especially the hemispheric one. It came by and talked about this about a month and a half ago, 2 months. I hope you guys listened to that lecture. Medications that you'll use in these cases will be usually nanosynephrine. Nitroglycerin is usually very rarely used because you're really going to be dealing with hypotension, not hypertension. Okay? The surgical risk is that when they open up the neck, they may actually injure the nerves. So you got to look for recurrent laryngeal nerve injury. Mandibular branch of the facial nerve is high. If the surgeon's going up real high to get to a plaque that's really high, then you can knock that out and get numbness. Okay, you can also knock out the hypoglossal nerve and vagal nerve on the side. You may also cause vascular injury from hemorrhage, stroke, or amaurosis fugax, which is like a TIA. The person will wake up with blindness in one side, which usually will go away. Hypertension is a postoperative complication, not really an intraoperative issue. And you really want to maintain really tight control on emergence. Okay? One of the drugs that I immediately pull out before anybody that emerges from CEAs is labetalol. Okay? And I'm really aggressive with it, 5, 10 milligrams at a time. So it's 1 to 2 cc's at a time to make sure that the blood pressure stays at under 150 systolic, or 160 is my highest. So I try to, at that point, bring the pressure back down to a more normal level, like 150 systolic. Hydralazine is too treacherous in the way I worry about it, because it's a great drug, but the problem with it gets too much reflex tachycardia, which is what I'm trying to avoid. I think of the way I look at carotids, I think of them as aneurysms that are ready to blow. They just put in a possible graft in place, okay, and they just repair the artery. So if you cause a shear pressure to be too excessive, you can destroy the anastomosis and cause bleeding to take place. So one of the things that I do is avoid increases in contractility, avoid increases in pulse rate, and avoid acute drops in afterload, which increases velocity and then causes more problems with shearing. Okay? So I usually will use labetalol as a decreased contractility, decreases heart rate, and maintains blood pressure, without causing too much of an acute drop. Nitroprusside is also kind of treacherous. You better be careful with it. It's a good drug, but it's again, you better be really careful with it, or you can cause a reflex tachycardia, which again, and it decreases afterload too. So I'm not a real wild fan about nitroprusside. I think labetalol is just so much safer. Hypotension sometimes will occur, especially if you've done bilateral carotids, and this is the second side they're doing, because now the actual carotid bulb's not functioning anymore, and you get a lot of people who develop severe hypotension with bradycardia. So what I do in that situation is, some people will tell you use neo, but usually the bradycardia becomes such a nuisance that I switch over to dopamine. And dopamine is usually maintained in the beta range. So you go to 5 to 10 mics per kilo per minute. Usually within 6 to 8 hours it resolves all by itself. Then you're able to wean off the dopamine, it's fine. But usually by the next day, the dopamine's off. So these people are really going to go to the what's called a step-down unit or to the ICU, depending on where you're at. They need to be watched carefully because the next set of complications I'm going to talk to you about. The biggest complication you have with CEAs is that a person can bleed. If they bleed into their neck, that you got a big, big problem in your hands. Okay? Because as it begins to bleed into the neck, it begins to push on the trachea and deviate the trachea past midline. And you can lose the airway completely. And I've had situations where the person comes back and everybody thinks, oh, their airway was fine the first time. And I said, you don't know what you're dealing with now. You've got venous congestion, okay, which means all the venous blood supply out of the larynx has been impaired. And now the person's larynx is going to be extremely edematous. So when you go in there and look, nothing's going to look normal again. Okay? It's going to look completely abnormal. And the size of the tube that you may have to put in would be a size that would surprise you. Instead of an 8 size tube for a male, you might have to put a 6 or a 5.5. If you're a woman, you might be as low as a 5 or 4.5. So that's how bad it can be. Okay? If you get into real severe trouble where the tracheal deviation is so severe, when you get in there, you won't be able to see the cords at all. You won't be able to identify it. You actually have the surgeon to cut open the wound, drain out the hematoma, and then the trachea will shift to midline, and then you'll be able to intubate. Okay, so be prepared for this. This is not one of those jokes. You want to get these people back fast. Okay, I've had at least 10 cases like that in my career. They're really, your epinephrine better be rolling at that point. So, the other thing that can happen post-operatively is the person may develop an acute CVA. Usually a bad sign. You want to make sure that person's airway is secured, oxygenating them 100%. Ventilate them appropriately. Don't hyperventilate them at that point. Make sure that they're maintaining perfusion by adequate blood pressure control. Keep your blood glucose levels controlled. If you're thinking that this person is not going to improve right away, consider cooling the person because hypothermia may actually be a little protective. Heparin, I am really kind of worried about at that point if it's hemorrhagic. Sometimes these will become hemorrhagic strokes, and adding anticoagulation therapy may be risky. So you've got to make sure that you're taking for CAT scan at that point to see what's going on. If you think somebody's having a CEA, immediately check the Doppler and listen to the carotid, see if it's still flowing. Sometimes after the surgery is done, the clot will form immediately in that carotid, and then it'll close down. And then if you hear nothing, then the person needs to go back right now for surgery, open that back up, declot, and then hopefully the person will respond to that therapy. But sometimes you will have an embolic phenomenon. It'll go up further into the head, so that's why you do a CT scan at that point. Eventually, some people will consider interventional radiology. You can also what's called malignant MCA syndrome, which is middle cerebral artery syndrome. This is an MCA stroke that's large enough to cause hemispheric edema, which then causes compression of the anterior and posterior cerebral arteries, and you get total brain edema, which then kills the patient. About 80% mortality rate associated with this. This is pretty bad. I've never seen this. I've read about it, but I've never seen it. Okay? I hope I never see it. The only way of treating this is do what's called a decompressing craniotomy, which is not a small procedure. It involves opening up the cranium and leaving the bone out. You take the bone and store it. Okay, the way we store it is we'll open up the skin and put the bone inside the skin and sew it back up. So it's left in a pouch. Then you'll come back later and get it. Some places will actually take the bone and then sterilize it and put it through the whole processing. But in usually traumatic injuries, like in trauma services where you're working in wartime, you don't have that availability, so you just take the bone and put it underneath the skin. It stays nice and sterile there. Acute hemorrhagic stroke, there's two kinds. There's intracerebral and subarachnoid. The worst one of these, of course, is subarachnoid, which is a small percentage, thank goodness. But the intracerebral is bad enough. Okay? If you look at intracerebral, it has 11% of CVA mortality. It's diagnosed with CT scan. And really the outcomes depend on the size of the hemorrhage. You have to think that the bigger the size, the more heme, which is toxic to the brain, may induce seizures. And the larger, of course, the hemorrhage, the more compressive effects on surrounding tissue, which leads to more cerebral edema and more likely to herniation and decreases the level of consciousness. Most people that have intracerebral hemorrhages deteriorate over the next 24 to 48 hours. So really, those people should be put in ICU and watch very, very closely. If they have any signs of loss of the consciousness, they should be intubated and at least try to maintain stability. Okay? Surgical evacuation is possible at times, and those patients should go back for the surgery if they have something that they can be fixed. The one that you have to worry about worse is subarachnoid hemorrhages. The hemorrhages occur into the CSF compartment, so you'll see blood in the CSF. Usually the location of the hemorrhage is either in the circle of Willis, where you have an aneurysm, or you have an opening of the artery from a hypertensive crisis. You can also see the posterior and anterior communicating arteries form aneurysms as well as rupture. The etiology usually is hypertension or aneurysms that have formed over long term, and what you'll see is blood when you do a CSF tap on these individuals. Neuro changes usually are clinical symptoms due to meningeal irritation, because when the blood gets extravasated in subarachnoid space, it immediately goes against the meninges, and meninges become irritated, so it becomes almost like a meningitis. So these people get nuchal rigidity. They get this really worst headache of their life. It's usually a very rapid in onset, and they get photophobia. So this is all signs of meningeal signs. Okay, so you might think that you have an infection. Usually with these people, you don't get a fever. Okay? And when you do a blood tap, when you do a CSF tap on them, you get blood. That tells you you got to be really careful. Hopefully, the person will not have an elevated intracranial pressure, because if they do, they may actually herniate when you do a CSF tap. That's why we don't really do CSFs anymore until we do CT scans. Almost nobody in the United States will dare do a spinal until they do a CT first, okay? Because there's been so many bad outcomes on people. EKG changes that you'll see is T-wave inversion, ST segment depression. Equipment that you'll need for diagnosing this is, of course, CT. And then angiography is also very helpful to find out where the aneurysms are at. You can also do what's called an MRA, which is a magnetic resonance angiogram, that also will pick up the aneurysms pretty well. Treatment is surgical clipping, and prevention of vasospasm is pretty critical. Endovascular stenting may also, including stenting and coiling. And anytime you see somebody hemorrhaging into their brain, doesn't matter if it's intracerebral or subarachnoid, is you need to consider anti-seizure prophylaxis. So usually phenytoin, dilantin is given ahead of time. You also want to sort of control their blood pressure, make sure it's not getting hypertensive, completely out of control. Subarachnoid bleeding may actually affect CSF removal, and the patients may develop hydrocephalus, so may require VP drains or VA drains. Vasospasm becomes a real issue, especially after neurosurgical clipping. It can occur up to 24 days after surgery, but usually occurs in the first 3 to 15 days. And when we worked in the ICU unit, we always had what's called triple H therapy, which is maintain them hypertensive, maintain them hypervolemic, and keep them hemodiluted. Okay, in other words, don't let them get high hematocrits, don't let them get dehydrated on you, and don't let them get hypotensive. The other thing that we invariably always did was we put an NG tube down in these patients, and we would put down NG nimodipine, which was in liquid form. You'd break up the capsule, and because most people couldn't swallow the medicine, if they could swallow the medicine, it was fine. You give it in capsule form. That's basically a capsule that has liquid in it. Once it gets in your stomach, it breaks open, and then you're able to absorb the calcium channel blocker. And it basically prevents smooth muscle spasms. This is how fast it works. In minutes, you'll see the vasospasm go away, and the actual velocity of blood flow increases dramatically when you're doing that. So nimodipine can be really a lifesaver in these people. What they usually do is continue this for up to 21 days after a subarachnoid hemorrhage. If you're doing an aneurysm clipping, these are big anesthesia cases. You want to avoid hypovolemia. You want to maintain cerebral perfusion. You really want to avoid aneurysm rupture, which is catastrophic. I've seen it happen so fast that somebody hemorrhaged into the infratentorial space that the brain actually herniated upwards, okay, and the patient died right in front of us. So you can lose control of an aneurysm pretty easily, especially at the last second. So it really is critical not to have any kind of brain motion at all, and make sure that person is fully muscle relaxed during this time when you're doing these procedures. Preoperatively, you got to do a full neuro. Make sure that you have adequate IV access, and make sure which is usually 2 IVs at the minimum, arterial line. And when you're doing clippings, I think everybody should buy central line. Okay, I think it's pretty important because you need to be giving vasoactive substances that work quickly. You can't wait for the agents to get from the arm to the heart. Induction is extremely tight control. You've got to get really good with inductions. Okay, you've got to be able to titrate the meds in, everything. What I found that worked well when we were working on people with aneurysms is that we would give a lot of esmolol. Okay, we would give them esmolol until heart rates are 50. So when we intubated them, they would respond almost minimally to the intubation response. We found that to be much more effective than fentanyl, high doses of it, or anything else. What you're trying to avoid is you're trying to avoid the shear effects, the shear force from rupturing the aneurysm on induction. So slowing heart rate's good, decreasing contractility is good. Avoid rapid decreases in afterload is bad, because if you give nitroprusside to somebody, what will happen is invariably tachycardia kicks in, and increases in contractility is a bypass effect as well. So you're actually increasing the shear velocity and causing more likelihood of rupture. So some people forget that. So we use, almost like I said before, esmolol is what we use. The other thing you want to do is you have a rapid induction period. You want to put the person awake to sleep. So these people are not somebody you want to give benzodiazepines ahead of time. You really don't want to give them a bunch of fentanyl ahead of time. You sort of want to talk to them, make sure they're okay, and then you put them to sleep quickly. Usually etomidate or propofol was what we used. It works very effectively. Barbiturates also will make you a very smooth induction, but since they're not available, we don't have them anymore. Methotrexate we still have available, but that causes seizures, so we don't use it. Benzodiazepines, because they're so long to take place, they're fine for hearts, but it's something that you want to get rapid control of ventilation. And giving high-dose narcotics may cause chest wall rigidity, which could be a real problem in ventilation. Again, this is something you don't want to have. So ketamine is also a very bad choice because it increases cerebral metabolic rate of oxygen consumption and drives your blood pressure up, which may also make it a very bad choice. Maintenance, volatile anesthetics usually are used, or TIVA. It depends on who you're working with. Some people are more believers in one way than the other one. I was always taught to use volatile anesthetics, and I felt very secure with them. Usually we use something longer acting like Forane. Never use SIBO in those cases. So because these are long cases, these are not short cases. This is a 4 to 8 to 12-hour case. Okay, and this microscopic work is looking at 3 to 4 hours. Okay, so this is a long, long case. You want to make sure that you're maintaining these people neuromuscularly blocked. You have a 0 tolerance to coughing or bucking. If you're right at the aneurysm and the surgeon's looking at it under a microscope and the person coughs, the aneurysm will rupture and game's over. So you have 0 tolerance for movement. You want to facilitate exposure. Sometimes the surgeon will be getting to the aneurysm and they'll say that the brain's too tight and I can't get to it, which means to you that you've got to hyperventilate. Even though it affects the blood supply to that area, you may be concerned about it, but at that point they need to facilitate exposure. So hyperventilation will be the appropriate thing to do. The brain will get less tight. The surgeon will tell you, I can see again, and then they'll be able to clip the aneurysm, and then you can reverse the hyperventilation as soon as you can. The greatest danger that I've seen is always at the time of clipping. When the surgeon is approaching the aneurysm, it's bad enough. But then when they're right on top of it, that's when the risk is greatest. The reason that is because most aneurysms have surrounding structures that are holding the aneurysm from rupturing. For the surgeon to get the clip on, he's actually had to dissect, away all these structures and push them out slothfully. Usually they're using Q-tips, and they're pushing the cerebral tissue away from the aneurysm. So now the aneurysm is completely on its own with no surrounding structures. So any fluctuation in flow resistance or anything that causes more shear damage, that aneurysm will rupture. And if you see an aneurysm rupture under microscopy, it's not bad, it's horrendous. Okay? It will be so bad that the microscope will be useless. And at that point, usually the person will exsanguinate, on you, or the surgeon will get desperate and take both carotid arteries and occlude them. So I've seen that done. I've seen the surgeon just grab the carotid arteries and occlude them, the blood flow drop, throw the clip in, and save the person's life. But you don't want to be there. So don't try to maintain that blood pressure completely controlled at that point, and keep a real close eye. That's when I'm usually standing on top of stuff with meds in my hands. I feel like the twin gunner, man. Got my nitroglycerin, nitroprusside in one hand, going like, okay, what do I give? A little labetalol, just make sure I have everything ready to rock and roll, because I don't want this person to shift at that point. And that person should have 0 twitches at that point. You want to make sure that there's no movement at that point. A lot of us will actually do what's called a post-tetanic potentiation test to make sure that that person will not move at all. Emergence is a prompt emergence, and you don't have to worry about promptness. Once the surgeon clips the aneurysm, it's not everybody goes high five and everything's great, but you still got at least an hour and a half to 2 hours before the person will wake up. So you got time. You got time to get the muscle relax and wear off. Don't go crazy. You don't have to reverse the person until you get 2 twitches back. And really what you want to do at that point is when you're emerging the patient, if it takes you a little longer, this is not like a carotid. Take your time. If the surgeon has had a really difficult time, if you're 12 hours into the operation and everybody's beat and the person has had a really difficult exposure, difficulty means that the brain has become edematous. Do not extubate these people. Okay? Leave them intubated in the ICU overnight. Take them to the ICU, put them on Diprovan drips, keep them comfortable, give them fentanyl, make sure they're comfortable so they're not getting hypertensive or everything, and then take them. If the surgeon feels that the exposure was easy and you can wake the patient up and you talk to the surgeon about it, then you can try to extubate at the end of the case. One of the things that's really, really dangerous is that a lot of times to get to these exposures, because these are subarachnoid, what does that mean to you? What does that mean? Where's the surgeon been working in the whole time? Where the CSF is at, right? Okay, so what did he have to do to get to the area where there's CSF? What did he do with all that CSF? Okay, it's all out. There's almost nothing left. Okay? So when you take this person to recovery, or you're waking this person up, what should you avoid? You can't take this person after you extubate them, take their head and put them up 45 degrees. You do that, the brain will slide right out of the calvarium, and you'll have subdural, subvenous hemorrhaging in the head. You'll shear the venous sinuses, and the person will die right in front of your face. These are not small cases. Okay, so if you get to do an aneurysm, consider yourself really, really lucky, but take it very seriously. And most of the time, there's only like 3 centers in all of Florida that actually do aneurysm surgeries. So they're pretty rare. Okay? Big cases. Vascular malformations are things that occur during brain development. They're usually congenital. Patients are often asymptomatic, and depending on which one you're talking about. If you look at the last 4, okay, which is the venous angioma, cavernous angioma, capillary telangiectasias, and arteriovenous fistulas, those are low flow, low perfusion issues, so those tend not to rupture. The one that you really have to worry about is the arteriovenous malformations. These are the ones that can kill you pretty quick because they're high flow. So they're more likely to shear. So when you look at the arteriovenous malformations, you'll see that the artery connects up directly to a vein. It's a high flow, rule resistant shunt. And the patient in adulthood can cause a hemorrhagic stroke that can be very severe. It may also cause a new onset seizure, and accounts for about 10% of the cerebral aneurysms that you may also see. You also will see in kids something very dangerous called the one that connects up to the vena gallon, which is a very large arteriovenous malformation. These are pretty bad news because they have a high mortality rate associated with them. They're hard to fix, okay, and you can see how big they are. And this is the normal size structure. These are pretty small in human normal persons, but in this kind of disease process, the dilation can start causing hydrocephalus, macrocephaly, and these kids will develop very prominent. You can see this kid has hydrocephalus, but if you see here, you see he has prominent head veins, forehead veins. That's what it's from. It's from the occlusion and the venous congestion inside the brain. May actually lead to high output cardiac failure in these kids as well. What you'll see in this is that this is a CT. This is a 3-dimensional CT to show you how big one of these structures can be. Pretty nasty to get to, you can imagine. Okay? You can't coil this. You got to surgically go after and resect it. It's not a joke. It has a very high morbidity and mortality rate with it. Venous angiomas are basically tufts of veins that many times are just asymptomatic, and you only find it when you do a CAT scan on somebody. These are low flow, low pressure lesions. They're rather hemorrhage or induced seizures, so usually don't require treatment. If you look at the cavernous hemangiomas, they form like a honeycomb of epithelial lined vascular tissue, and usually they have no intervening neural tissue inside of them. They're low flow as well, well circumcised lesions, and they have well-defined hemosiderin and calcification often present, which is consistent with why you see seizures in these kids. Angiograph sometimes will be negative because the blood flow is so low that your angiogram won't enhance. So you'll see it only on the CT. Presents with hemorrhage or seizures rarely. Sometimes if you have that kind of symptoms, then they go for surgical resection, but they're not really amenable to embolization because of the low flow that you're seeing in these individuals. Capillary telangiectasias are a little bit more difficult to see. They are also low flow and large capillaries. Angiographically, they're silent, they're difficult to pick up, and they really have a very low risk of hemorrhage. They're usually associated with the Osler-Weber-Randu syndrome, or as well as Serge-Weber syndrome, and usually we don't treat these at all as well. The arteriovenous fistulas are direct communications between the artery and vein. Usually these are the meningeal ones that are in the dura and between the carotid artery and the venous sinuses. They tend to spontaneously occur from trauma, and they're also post-traumatic. And they can become a problem. And sometimes these are more likely resectable. If you look at the last part of the discussion, which I'm running out of time, is congenital malformations of the brain. Is the Arnold-Chiari malformations. The Arnold-Chiari malformations are herniation of the top of the cerebellum into the cervical spine. So this is a foramen magnum that's not properly formed. Part of the treatment is actually removing part of the foramen magnum and making it bigger so it doesn't herniate any further and it relieves the pressure. You also will get arachnoid adhesions that may cause obstruction in the fourth ventricle and leads to an elevation in ICP and hydrocephalus. These kids usually come in with occipital headaches, and they say the headache's worse when they cough or they move their head. And associated with this is also serenomelia. Serenomelia is basically when the CSF begins to accumulate down in the spinal cord and starts giving you a compression syndrome inside the cord, which causes damage to the spinal cord itself. It's a progressive cavitation of the spinal cord. Normally, if you look at the actual spinal cord, there's actually a middle canal, which is a central spinal canal. That's pretty small, but in serenomelia, this gets very large. You can see how big it is. It becomes to compress on the surrounding spinal cord tissue, and it can lead to sensory and motor deficits. The motor deficits we've got to be very careful of, because if you give these people succinylcholine, you can get a hyperkalemic arrest on your hands. Tuberous sclerosis is one of those rare autosomal dominant diseases that causes benign hemartomas that develop over the face. The reason this is important for us, if you take care of somebody, I've never seen this, I've seen it in clinical, but I've never seen it in the OR, is that these people have, unfortunately, some degree of mental retardation, depending if the tuberous hematomas form in the brain. So it can cause mental retardation, which makes them difficult to manage. But also the airway becomes an issue because it also affects their face, and it may be difficult to mask these patients. Okay? They're also associated with Wolff-Parkinson-White syndrome. So when you see these people, you have to take care of the mental retardation becomes an issue. Preoperatively, you got to assess the airway, make sure that you can mask the patient adequately. Sometimes tumors that the reason they're coming in is because the tumor is affecting their ability to breathe. So they need actually a tumor section, and so you got to make sure that you can be able to ventilate and intubate these individuals safely. Look for an EKG, even though they're young, because they may have WPW. So you got to make sure that you about 10% of them will have WPW. So you really have to get an EKG on somebody, even though they're young, to rule that out. Do your neuroexamination, make sure that you don't have any other neurological problems. Induction, succinylcholine, you got to be very careful with. If you have any weakness, then this person may induce a hyperkalemic arrest again. But otherwise, it's considered routine anesthetic management once you get them airway secured. Then there's a von Hippel-Lindau syndrome, which is the last one to talk about. And actually, neurofibromatosis is next. It's an autosomal dominant with variable penetration. So if you have a parent who has an affected gene in a normal mom, 50% of the kids are going to have the affected gene and become symptomatic. What they develop is angiomas and tumors. They can actually get retinal angiomas, which causes blindness. If it affects into the brain, it causes cerebellar problems, as well as, of course, brain compression. And in the spinal cord, they maybe limit your regional anesthesia. So be very careful with people with von Hippel-Lindau. Don't do regional on them. It's not neuroaxial anesthesia. What's really scary about this disease, it has a 10% association with pheochromocytoma, which can be, of course, has a very high mortality rate if you take this person out. Then you got the last one we'll talk about, which is neurofibromatosis, which is an autosomal dominant disease, also known as von Recklinghausen disease, also called elephant man's disease. You've seen the movie. These people present initially with cafe au lait spots, and then they develop hematomas or neurofibromas all over their body. These are partly neural tissue
that's overgrowing at too rapid a rate. They're all over the skin, and what they may actually do is they start causing compression syndromes against the trachea, the airway, and they may have to be resected. You cannot resect all these tumors because they just keep coming back. So you only resect what's needed in the sense of what the person cannot live with viably. Neurofibromatosis can be so severe that it has caused people to lose their face completely. And the first facial transplantation done was on a patient that had neurofibromatosis. It can be a devastating disease. There also has orthopedic abnormalities where you'll have the actual neurofibromas invade into the bone itself and cause loss of the actual joints. And they also have a slightly increased incidence of cancer.